welcome respected faculty members, delegates, my colleagues, and support function from the hotel for this important event. This Orient Conclave is basically has started at the same place as we say last year in October 2017. We started Orient, and since then Orient has given a lot of interesting platform, very inspiring platform to all the ENTs. And we at Inspira, we have believed that we provide such an academic platform which itself is a benchmark. And right from the last year, if you look at an Orient program per se, we have seen not only the conclave, but also we have done live surgery programs, we have done zonal Orient ETP programs, but the most important of that is the Orient Facebook community. That one Facebook community which we have is around 3,000 plus ENT doctors who are there, and it's a closed group community. It is driven by doctors. The content which is available is created by the doctors, and nobody else from any industry or pharma industry is available on that group. And we have seen it's been very successful, and within a matter of 9 to 10 months, we have now 3,000 plus doctors on that platform. From Inspira, what we believe and what we want to commit here in front of you is that we would definitely love to provide this kind of or even better academic platform to all the doctors and live the mission of CIPLA and the Inspira. The idea of entire academic program is to enrich the practice of all the ENT community which is there. And in that process, we find ourselves a very proper, a good facilitator for this entire academic event. If I take a step back and look at last year's program, I guess it has been a successful. And why the reason why I'm saying it is successful, because the academic content which was there, we have got a lot of appreciation for that. And this year also, you will see the agenda, you will find this has been a very enriching one as well. And I want to thank Dr. Seema Sheikh. Thank you so much, sir, for providing that content and getting the so-called ignited minds of otorhinolaryngology here at one platform to conduct this entire special program. With this, I'm assuring you all that we will have this level of academic programs going forward. But to take us through for the last 1 year what CIPLA as a company or we as a division Inspira have done it, we have a video. Can we have the video, please?
CIPLA's journey of 1,000 miles began with a single inspiration to harness Indian expertise for self-sufficiency in the chemical and pharmaceutical industry in India. It all started in 1935 with two scientists and a vision established by an exemplary visionary, Dr. K.A. Naid. In 1935, CIPLA continues to honor the promise made to Mahatma Gandhi on July 4, 1939 of making essential medicines affordable to Indian patients. CIPLA today has an array of 1,500 plus products, over 50 dosage forms, 20 plus world's first innovations in R&D, over 44 state-of-the-art manufacturing facilities, over 20,000 employees, and presence in over 80 countries. Our work is not just about making medicines, it's about making a difference. With more than 80 years of making history and creating the future, with one goal of caring for life. Carrying forward this legacy of none shall be denied, of quality and affordable medication, we launched CIPLA Inspira, delivering happiness. In CIPLA Inspira, we share a unified vision of delivering happiness and doubling the smiles of every life associated with us, be it healthcare providers, patients, pharmacists and employees. CIPLA Inspira reaches out to more than 80,000 doctors with focus on ENTs, chest physicians, consultant physicians and general practitioners with a comprehensive portfolio of anti-allergics, anti-infectives and API. Cipla Inspira aims to serve healthcare providers with a holistic approach, with a vision to cater otorhinolaryngologists across India, with the help of customized academic initiatives like Talk, a regional forum where ENT specialists meet to discuss on management and advancements in the field of otorhinolaryngology. Arise, a patient education initiative for creating awareness on allergic rhinitis. ARC, Allergic Rhinitis Care, an initiative which aims to deliver knowledge to doctors and care to allergic rhinitis patients. Orient Live, a live surgery platform where eminent surgeons in the field of ENT share their skills and expertise for effective surgical outcomes in the field of otorhinolaryngology. Orient Facebook Group, a community with more than 3,000 ENTs connected via academic initiatives and surgical workshops. Cipla Inspira has taken the academics in ENT fraternity a step ahead by successfully organizing First Orient last year. Now the time has come to view the grand academic event in the field of otorhinolaryngology. Cipla Inspira welcomes you to its second National ENT Conclave, a vision translated to reality for the second consecutive year. Orient, with eminent faculties from national and international repute. Topics dealing with advances and excellence in otorhinolaryngology. A program where we aim to achieve breakthrough to excellence in otorhinolaryngology. At Orient 2018, fusing ideas with experience.
So now I invite Dr. Simaf Sheikh, who is the Chief Convener of the Orient program, to come and say a few words.
Good evening everyone and welcome here for our second ENT National Conclave at the Orient. I'm going to restrict myself to very few words. I think Samir and Shali have done their bit and have really given you a very good idea as to what the conclave is all about. And it would be very unfair for me to kind of take undue credit for doing anything except the academic program. And whatever else they've done here, you can obviously see the logistics and the way this is handled. The only thing that I would like to probably point out here is, one of the best things that I like about this team is the fact that they're very proactive. Orient was conceptualized just about 6 months prior to our first Orient Conclave last year, and within 6 months we were able to do a very wonderful academic deliberation program, and the same thing continues this year. And the best part of it all is the entire team that works together here none of the business development heads ever interfere with the academic content and the scientific program. That's the best part of it. So there are no reasons to have anybody there except for the academic content for them to be standing here and deliberating with all of us. So with just these few words, I thank you all for being here. Enjoy your stay here. Enjoy the academic feast that is being cooked up for you all. And we hope to keep it well on time, although we've started late. So I would encourage that whatever we need to do, we keep within the constraints of time. And we've selected topics which are going to be practically useful to you on a day-to-day basis, and I hope that helps. So your feedback at the end of this all is going to be really helpful for all of us to make it better year after year. Thank you very much.
Thank you, sir. So now we start with our scientific program. We have a little bit changed the sequence of the sessions. So our first session is appropriate selection of antibiotics in ENT infections. And I invite Dr. Simaf Sheikh to come and chair the session. Dr. Simaf Sheikh is a known name in the field of OSA in India. He is primarily responsible for the spread of awareness and treatment of OSA in the ENT fraternity of India. He took keen interest in this field since 2007. He was elected as a founder president of IASSA, Indian Association of Surgeons for Sleep Apnea. He is now in high-level talks with the Central Ministry to try and get rules and regulations for the pre-employment checkups for OSA. And it was he who has really spearheaded the motions to get OSA and its surgical treatment covered via insurance companies also. He is responsible for bringing the concept of dynamic MRI in evaluation of OSA, and this concept has been accepted by many of the Western groups in their protocol of evaluation. He is at present HOD ENT at Inamdar Hospital, Pune, and his consultant sleep specialist attached to KEM Hospital, Pune. So, sir, over to you.
Yeah. Thank you. Anyway, this wasn't planned. I wasn't supposed to come back up immediately from there to here, but we've changed the whole thing. So the next one we're going to start off is with Dr. Bharat Purandre. He's a well-known, renowned infectious disease specialist from my very own city at Pune, and he is the consultant at Dinanath Mangeshkar Hospital. Now, one of the reasons why he's here is because he does extensive work in these fields. And just like last year when I had a program on Pseudomonas as an infection for our ENT, what I realized at the end of the program was that entire program and that talk was related to Pseudomonas infection in the year only. And the infections that we are facing on a day-to-day basis, we are probably not doing the right kind of selections. That's why we are having resistant strains for us to be dealing with. So I've asked Bharat to come here and give us a very good insight as to what we need to really look into before we decide the appropriate antibiotics for our use. And I'm sure he's going to enlighten us before he leaves. So over to you, Bharat. Thank you. Thank you for being here.
So thanks for inviting. Am I audible at the last? Am I audible at the last? Okay. Thanks, Dr. Seema, for inviting me here and giving me an opportunity to speak in front of this august audience. And I greet all these colleagues who have come here to this August conference, and please enjoy the academic piece. At any point of time, you feel that you don't have understood something, you want to ask something, it's going to be a co-learning for all of us. So you can stop me at any point of time and ask questions. So the topic which was given to me was infectious disease and ENT, which is a broad topic because the infections can happen to each part of like ENT practice, ear, nose as well as throat. But I have selected a few for today's talk. So in today's talk, I am going to talk about common infections which we encounter in the ENT practice, OPD as well as IPD. There are a few diagnostic pitfalls which I am going to deliberate about. I am going to have a little bit conversation about mucormycosis, which is a very important infection, and ENT is the principal treater for this particular infection. Malignant otitis externa, another difficult to treat infection. Then I will have some word about skull-base osteomyelitis and laryngeal infections, and in between these slides we'll have some questions for which you all have got voting pads, and I'll request and urge you to please give your answer A, B, C, D whenever that question comes up. So regarding common infections in ENT, I have selected these infections. I am sure that the list is very big, but pharyngitis, tonsillitis, infectious mononucleosis, otitis media, rhinosinusitis, parotitis, Bell's palsy, and nasal furonculosis, which I thought that I would be putting some light on. Now, I am not going to details about pharyngitis because you know how it presents. It presents with pain, regional lymphadenopathy, fever and malaise. But remember that most of the pharyngitis, most means approximately 50% or more, is caused by viruses, respiratory viruses, and therefore antibiotics may not be effective for most of these viral infections. Amongst the bacteria which cause pharyngitis are the commonest ones are group A streptococci, which are also called as GAS or gas, other streptococci, particularly group C and group G, and then certain other bacteria, the family of herpes viruses, especially HSV1, HSV2, cytomegalovirus, Epstein-Barr virus, and even HIV also can cause pharyngitis. Now, those people who practice in tropical areas also know that some cases of dengue and even measles also present with a significant element of pharyngitis. And then it is not always going to be easy to differentiate viral versus bacterial pharyngitis. I saw many ENT surgeons advising ESR and CRP, and then they feel that if the CRP is high, it may be bacterial, and if it is low, it may be viral. But it is not so, and even in viral pharyngitis also you can have a high CRP. So it is not really going to be a differentiating feature. Oral candidiasis is also an important cause of pharyngitis, and then there are non-infectious causes like GERD, smoking, vocal strain, Some drugs, especially ACE inhibitors, are a cause of pharyngitis and a persistent cough, and certain autoimmune or ill understood conditions like Behçet's and Kawasaki also. Amongst bacterial cause of pharyngitis, the most commonly we encounter is group A streptococcus, and for which a rapid diagnostic test, an antigen test is available. I don't know how many of you make use of that test, but it's a very simple test. Just take a throat swab and within 1 or 2 hours you will get the results. There are certain serious or warning signs of pharyngitis, which I think you all people know, that if somebody develops stridor, drooling of saliva, breathlessness, or hot potato speech, it may be a warning sign of laryngeal edema also. And before I go to the treatment of pharyngitis, I thought that this table might be useful for my ENT colleagues. Like, how will you differentiate between the bacterial versus viral? And then you will opt for antibiotics for those who are looking more bacterial. But this table is not sacrosanct, and there always will be some cases which are borderline. So remember that whenever you get an exudate over the pharynx, which is a frankly purulent exudate, or you get a tonsillar exudate, that generally happens with bacterial sinusitis, pharyngitis, and then not with viral, except for the Epstein-Barr virus, which is known to have a exudate on the tonsil. In bacterial pharyngitis, the redness of the throat and the patient's fever are generally proportionate, whereas in viral pharyngitis, you will get a very high grade fever, but if you see the throat, it is not that bad. So if you get somebody 103 and 104 temperature, but the throat is not looking that bad, that could be viral and particularly influenza. Now symptoms such as runny nose, sneezing are less common with bacterial, and they are very, very common with viral. So you ask your patient that whether you have a runny nose, do you have sneezing, that will favor viral etiology. Myalgias are common in viral and not bacterial. Then if you get a scarlet type of rash or strawberry tongue, that is a feature of group A streptococcal infection, which we will not see in viral pharyngitis. But in viral pharyngitis, sometimes you can get an oral enanthem or exanthem, and I am pretty sure that most of you can definitely differentiate between what are these. And if that thing is found, then that is usually viral. Then rather than ESR and CRP, I will advise that you go for a WBC count. So if you find a WBC count which is higher, then it's probably going to be bacterial. Whereas if it is a normal WBC count with a relatively low lymphocytic count, so absolute lymphocyte count which is lesser than say 20% of the total WBC count, that will favor a viral etiology. So when you just find these viral features and patient is coming to with a high grade fever, I will advise that think about influenza as a possibility and start oseltamivir, because you may be the first person who is coming in contact with that particular patient. Whereas if it is bacterial, then obviously we'll have to go for antibiotics, and this table will give you antibiotics. I mean, you all know what antibiotics are to be given for pharyngitis, but the point which I wanted to make while putting this table was that the treatment for bacterial pharyngitis is not 3 days, it is not 5 days, and it is not 7 days, but it is for 10 days. So if you are using penicillin V, see the dose is 500 mg TDAs for 10 days, and why it is so is because we have to actually eradicate the streptococci from the throat. If we don't eradicate them from the throat, you know that it can cause repeated attacks of pharyngitis, or it can cause certain late complications such as post-streptococcal glomerulonephritis and acute rheumatic fever and so on. So eradication of that streptococci is important from the throat, and for which it is going to take a longer time. So the only short course which is seen in this table is azithromycin. So if we can use azithromycin, the dose is 500 mg on day 1, and then it is going to be 250 mg from day 2 to day 5, and that 5 days treatment will be sufficient, because azithromycin is a very long acting drug. It has got a very long half-life, almost of 5 to 6 days, and that's why you can stop at 5 days. But for all other antibiotics, you can see that the doses are around 10 days. And for this pharyngitis, remember, you don't have to give third generation cephalosporin. Many people, I find that they give cefixime or a combination of cefixime and linezolid because some pharma company has made it available. But for group A streptococci, you don't need higher antibiotics. You can do well with cephalexin or first or at the most second generation cephalosporin, or even cefadroxil is also fine. And you don't need to go to second or third generation cephalosporins. Somebody who is allergic to penicillin or other drugs, you can use clindamycin. Now tonsillitis treatment is similar to pharyngitis, and etiology is also similar, and treatment is also similar. And to this audience, I don't think I have to tell you the reasons of tonsillectomy, but many people, when they have been advised by the ENT surgeons to go for a tonsillectomy for repeated tonsillitis, they sometimes come to our opinion, is it right, should I go undergo tonsillectomy? So generally there are decided rules, and all of you I believe know the Paradise criteria, where we go by those criteria, and if the patient is fitting into those criteria, patient will be advised tonsillectomy. Now this multiple choice question is coming up. So you see this figure carefully. Is it visible at the last properly? And now please take your voting pads and choose that what's your diagnosis for this patient in the previous slide. How many of you think that it is A, streptococcal pharyngitis, B, adenovirus, C, oral thrush, and fourth, I don't know. So voting time is clicking. Okay, so can we have the votes? So I go with the audience. It is definitely curd-like white patches, and it is going to be oral thrush or oral candidiasis. Now treatment for this particular infection is really going to be very simple. Either you can give them a candid mouth paint, or you can give them fluconazole tablet, and the dose is 150 mg only. 150 mg for 5 to 7 days. Once daily will be enough. Now there is no MCQ for this. But just see this lady who has got enlarged tonsils. I don't think I could actually depress the tongue while taking this photograph, but all of you can see that the tonsils are enlarged, and there is a very, very purulent exudate on her tonsil, and she is a 17 years old lady. So after seeing this, what comes to your mind? There is no MCQ, but this is infectious mononucleosis, and she was later proven to be having a positive antibody for infectious mononucleosis. So this is an infection which is caused by Epstein-Barr virus. It is common in adolescents, and because it is transmits by salivary transmission, it is called as kissing disease. Now this disease has got very characteristic features of fever, a tonsillar exudate, even though it's a viral infection, but like a bacterial kind of exudate comes over there, and you get typically posterior cervical lymph nodes. In general usual pharyngitis, which is called the streptococci, you get anterior cervical tender lymph nodes. Here you will get posterior cervical lymph nodes, which are quite large. They may be tender, and main symptom of this pharyngitis is generally pain during swallowing, and they don't come with very high grade fever or very sick toxic look, and it just goes on for 1 or 2 weeks, 3 weeks, and they don't respond to antibiotics. That's how they will present. So now please answer this MCQ with your voting pads. What is true in mononucleosis? Option A, can you get a WBC count of 17,000 with 75% lymphocytes? Option B, do you get hepatosplenomegaly or hepatomegaly with altered LFT? Option C, can you get splenic rupture in infectious mononucleosis? And option D, can you get all of above? So please vote. So now let's see how audience has voted. So it's nearly equally divided between A, B and D, but I think it is D is the correct answer, because all of this can happen. See, in a normal pharyngitis you will hardly get LFT derangement, you will hardly get splenic enlargement, but if you find that your patient is having posterior cervical lymph nodes in addition to tonsillitis, and they have got hepatosplenomegaly and LFTs are abnormal, and you get a lymphocytic leukocytosis, that is in favor of mononucleosis. Generally treatment is going to be supportive for mononucleosis, but sometimes some people who have got prominent obstructive symptoms, we may give them a short course of steroids. Acyclovir doesn't work in infectious mononucleosis, so there is no point in giving acyclovir. Now I think you all know about otitis media, but I just made this one slide that it's an acute illness with inflammation of the middle ear space, and there is usually an obstruction of the eustachian tube, and that's why there is a fluid retention in the middle ear cavity, and there is an acute suppuration. Now this syndrome has been divided into these 4 categories: acute otitis media with effusion, mastoiditis, and chronic otitis media. Remember that the commonest organism for otitis media is Streptococcus pneumoniae, which is a cause of meningitis also and pneumonia also, but it is one of the most common organisms which causes otitis media. And the other organisms are Haemophilus influenzae, group A Streptococci, Staphylococcus aureus, and Moraxella. So when you see these organisms, obviously the antibiotics become very easy to be given, because the antibiotics have to be directed against these 4 organisms. So even if you end up giving amoxicillin in a dose of 500 mg TDS for an adult person, or cephalosporins first and second generation for 5 to 7 days. That should be generally sufficient for treating otitis media unless some complication has happened. Now most of the rhinosinusitis is viral, nearly more than say 60-70% is viral. But if the symptoms do not resolve by 1 week of time in supportive care, then generally it can be bacterial. And the causes of bacterial rhinosinusitis are almost the same as the causes of otitis media or pharyngitis. So that means it is going to be streptococci, Haemophilus influenzae, these organisms. The treatment of choice is amoxicillin clavulanate. So you can use a dose of 625 milligrams 3 times in a day. Remember that many of our physicians are fond of giving doses twice in a day. Give 620 twice in a day, it is less dose. If your patient is around 50 kilos, give 625 mg 3 times in a day. If the patient is hefty 70, 80 kilo person, give 1 gram twice daily, no problem. But do not underdose these patients. You can give doxycycline 100 mg twice daily, or clindamycin 600 mg thrice daily, or cefodoxime 200 mg twice daily. Or you can use a respiratory quinolone such as levofloxacin or moxifloxacin. Generally 5 to 7 days treatment will be enough for most of the rhinosinusitis, in addition to the decongestants and all other treatment that we give. About macrolides, many people are fond of giving roxithromycin, azithromycin, clarithromycin for rhinosinusitis, but there is a rising resistance in Streptococcus pneumoniae for these antibiotics, macrolides, and therefore macrolides are generally not supposed to be a drug of choice for rhinosinusitis. So if you get a patient for rhinosinusitis, go for these antibiotics, amoxiclav, doxyclinda, cefodoxime, respiratory quinolones. Now one line about this parotitis, Bell's palsy and nasal furunculosis. Many of you will come across patients with parotitis, generally caused by staphylococci or streptococci. Obstruction of the parotid duct may be present. So we give them oral rinses and we give them anti-staphylococcal antibiotics. So when I say what is anti-staphylococcal antibiotic, the answer is the antibiotic should be directed against the methicillin sensitive Staphylococcus aureus. So generally what are those antibiotics? One is cloxacillin, excellent anti-staphylococcal antibiotic. Remember that amoxicillin is not an anti-staphylococcal antibiotic, but cloxacillin is. So you can give a dose of 500 mg 6 hourly for staphylococcal infection. Then there is a flucloxacillin tablet now available. So that also you can give at a dose of 500 mg QID, and cefazolin or cephalexin. This can be given for staphylococcal infections. You may be coming across Bell's palsy also, I think frequently. So it's an infranuclear 7 cranial nerve palsy. Most common cause is either activation of herpes simplex virus or varicella zoster virus, and therefore we generally treat them with a short course of glucocorticoids. So like 60 milligrams of say prednisolone for a 60 kg man, and then we go on quickly tapering it, and within 7 to 10 days we stop the corticosteroids. Valacyclovir at a dose of 1 gram thrice daily, generally for 5 to 7 days is given for most cases, but there are clinical trials suggesting that this may not be a correct strategy, because nearly 50% may be VZV and HSV, other 50% may be either idiopathic or some other cause. And again, because there is a exposure keratitis, eye care is also required. About nasal furunculosis, it is generally caused by staphylococci because nasal septum is a favored site of colonization by the staphylococci, and it's acutely painful swelling happening there, and generally you get an edema of the nose or of the lip, and because it is there in the danger area of the face, a quick institution of anti-staphylococcal antibiotics should be done. So when I say anti-staphylococcal, think about cloxacillin, flucloxacillin, cefazolin or cephalexin, because they are the anti-staphylococcal antibiotics. Now these rare infections also you may be coming across. About diphtheria, I don't need to tell you all this audience that diphtheria is a very important illness. We are seeing that illness rarely. I come across maybe one diphtheria in 6 months. You may be coming maybe frequently than me, but the drug of choice for diphtheria you all know is going to be erythromycin. Then you can also use clarithromycin also for diphtheria, but you generally our beta-lactam antibiotics, they generally do not do well, and that's why the drug of choice is erythromycin or clarithromycin. Then I don't think with the short time I can elaborate more about this. I'll go to a more important topic that I want to talk to you about, and that's about mucormycosis. So mucormycosis happens in 3 stages. So first of all, the maxillary sinus will get colonized with the spores of the mucor, and when they'll find that there is an adequate number of spores are there, the host is immunocompromised, the sugars are not controlled, there is a diabetic ketoacidosis, then the invasion will happen into the mucosa of the maxillary sinus, and finally the infection will establish and start growing. So you see this particular case, it's a very typical case of, even if you see that person and you ask, are you diabetic? And he says, I am diabetic. Then you start thinking about mucormycosis when this kind of presentation happens. So this was a 65-year-old man who was having diabetes, uncontrolled sugars, and he got admitted in DKA. He was acidotic and he had complaints of pain in his left cheek, but there was no fever, and there was unilateral bloody nasal discharge from the left side of the nose. There was left eye swelling, there was proptosis, and on examination there was tenderness over the maxillary sinus, and when you see the hard palate with a torch inside, you found that there is a necrosis beginning over there on the hard palate. And when the ENT surgeon bent inside the nostril, he got a swab from the affected area and it demonstrated broad aseptate hyphae. So it's a clear-cut case, isn't it, of mucormycosis? Or do you think that that man could have orbital cellulitis? Or was it aspergillosis? I have given you this information for this patient. And the last, I think, the point is more important, that there were broad aseptate hyphae from the sinus. So now I will request the audience to vote for A, B, C or D. Please start the voting time. Sorry. So let us see what the audience has voted. Oh, so still, I mean, C was a good proportion thought that it is C. See, when you get a broad aseptate hyphae from the smear, this is the description of the mucormycosis. For aspergillus, you will get a narrow, thin branch and septate hyphae. Aspergillus is always septate. So when they say aseptate, it goes in favor of mucor. And again, diabetic ketoacidosis, everything will go to be favor of mucor. Although sometimes there is a difficulty in differentiating between the two. Sometimes the microbiologists or lab people confuse us, but this is a classic description of mucormycosis. Now, rhinocerebral mucormycosis is a rare infection. It's not like that very common. We come across around 8 to 10 cases of mucormycosis in a year. So it's not like very common, but it's a rare, but it is there, and we see cases. It happens in the sinuses. It happens in the nasal passages. Sometimes it erodes into the oral cavity, and sometimes it goes up and goes into the orbit and even into the brain. And this is caused by these all species of mucor: Rhizophus, Rhizomucor, Mucor, Absidia, Cunninghamella, Saxenia, and so on. It's an invasive disease. It occurs in people who have got poorly controlled diabetes, especially those who have got acidosis, because in acidic environment the fungi really thrive. So you see this lady, how sick and toxic she is. There is almost proptotic or bulging eye with lot of chemosis of her conjunctiva. If you see the MRI, it is the whole of the sinus, and even the orbit is full of the fungus. And once you get the culture growth, you will see this kind of a beautiful fungus, but it is causing havoc inside this particular patient. It can lead to various complications. It can cause carotid arterial occlusions, and patients can develop stroke while they are on treatment with mucormycosis. It can produce cavernous sinus thrombosis. It can produce infarction, because fungi are actually thrombotic in nature. When they invade the vessel, they produce thrombosis. They can cause coma, they can cause death, CNS hemorrhage, abscesses, cerebritis, and blindness. Treatment of choice for mucormycosis is IV amphotericin B. So if we end up using a plain amphotericin B, deoxycholate, dose is 0.7 to 1 mg per kg, and if we give liposomal, which we frequently use now, the dose becomes 3 to 5 mg per kg. And please remember that the duration is at least for 4 to 6 weeks. Guidelines are saying that it is going to be for several weeks after the patient has achieved clinical as well as radiological stabilization. But most important part of treatment of mucormycosis is extensive and repeated debridements. And sometimes those debridements can be really mutilating. Patients can end up getting removal of the eye, removal of the palate, and extensive reconstruction later may be required. So the treatment is liposomal amphotericin B, 3 to 5 mg per kg for 4 to 6 weeks. Now many ENT persons ask me, we have already given 2.5 grams of amphotericin B. Do you want to give more than that? The answer is now that concept is gone. So you now do not calculate the cumulative dose of amphotericin B. You calculate the duration. I have given for 4 to 6 weeks, yes, then that can be enough. Now in that 4 to 6 weeks, you may have given 2 grams, you may have given 12 grams, you may have given 20 grams, because if you are using liposomal amphotericin B, it is going to be in 10-12 grams also, almost. So don't calculate the cumulative dose, calculate the duration and give for at least 1 or 2 weeks after the patient has achieved complete stabilization. No new necrotic tissues appearing in the nasal cavity, MRI showing the resolution or maybe stabilization of the disease. After that time point, you treat him for 1 or 2 weeks, because some spores may still be present which may not be visible to the eye. Now additional drugs can also be used for mucormycosis. So we can use posaconazole, we can use hyperbaric oxygen, we can use ion chelation, because this fungus has hydrophores on its surface, and it's a ionophilic fungus, it's a ferrophilic fungus, it wants iron for its growth, and that's why generally blood transfusions are going to be avoided in mucormycosis, because with more and more blood transfusion, more iron overload will happen, and in iron overload state, this fungus is going to thrive. So we chelate the iron so that the fungus becomes less, but it's an adjuvant therapy. The main part of therapy is going to be debridement. So in that slide I have put in faint, don't think that the treatment of mucormycosis has begun unless adequate debridement is done. So unless the debridement is done, the treatment has not begun. So just giving amphotericin B is not going to serve the purpose. Why? Because the amphotericin B has a poor penetration into the maxillary sinus, because most of the arteries which are leading to that sinus will be thrombosed because of the fungus. But still it is a drug of choice. But we have to do debridement so that the blood vessels become open and the ampho B can reach the sinus. And remember that even if the fungus is dead, according to the many NT surgeons say, I had gone inside but the fungus is dead. But even those dead non-viable hyphae can adhere to the blood vessels and precipitate thrombosis. So once they precipitate thrombosis, the drug cannot go inside. So even the dead tissue has to be removed. The treatment duration, as I told you, is going to be unclear, but it is going to be really in months. It's not going to be in days. It's going to be in months. 1.5 months is the minimum. Sometimes we are given up to 2.5 months also. And do not try to calculate the cumulative dose of amphotericin B. Just see for the toxicity of amphotericin B, because it can cause creat elevation, it can cause hypokalemia, so that we have to see. But do not see the cumulative dose of amphotericin B. And sometimes some ENT people say that it is a very difficult disease, patient is very old or already stroke has happened and therefore we can't do much of surgical debridement. You do whatever medically you can do. In that case, we do this maximal medical therapy. So when the surgical side cannot do much, if the mucor has already gone into brain and one cannot operate him, it has gone into the skull base and operation is not going to be possible. In that case, these 5 things we use. So we give the patient IV amphotericin B, we give them IV posaconazole. In addition to that, another antifungal called caspofungin, ion chelator called deferrasurox, statins and aspirin. Now I'll think I've got very less time remaining, so I'll just treat this one single condition of malignant otitis externa. The malignant otitis externa, most of you must have come across this condition. It's also called as necrotizing otitis externa. Generally, this patient is very typical, an elderly diabetic man walking into your OPD and is saying that there is a ear discharge happening for months, it's just not going. Once you examine, you find a green pus over there. This condition is characterized by aggressive clinical behavior, and even if you treat them for 1 week, 2 weeks, generally the response is not that good, and it is a high mortality rate because it can invade inside and go into the skull base. Generally, infection starts into the external otitis meatus, but it spreads into the adjacent soft tissues, cartilage and bones, and they will typically present with severe ear pain and otorrhea. So this begins like this on the left hand side and then may turn into what is seen on the right side. Now treatment includes basically good glucose control, good toilet of the oral cavity, and sometimes you will also need very high level antibiotics, because Pseudomonas is now becoming very resistant. Now many ENT persons ask me, if Pseudomonas is there, what antibiotics I can give? So answer is, we have got limited options for Pseudomonas. If you see the culture report, it will show that most of the drugs have become resistant. But generally what works are carbapenems. So imipenem does work, meropenem works, doripenem works. Sometimes you can come across certain Pseudomonas which are only susceptible to colistin. In that case, there is no option but to give them colistin. Now a new option has also come called as polymyxin B, which is less nephrotoxic, that can also be used. Remember that tigecycline, ertapenem, they don't work against Pseudomonas. So sometimes lab may erroneously give you this drug works, but they don't work against Pseudomonas. Some of our ENT friends are favor a product called as paropenem, and they feel that it is a carbapenem. But I take this opportunity to tell you that it is not a carbapenem, it's a misnomer. It is paropenam. It's a different class of antibiotics, and its action is similar to first or second generation cephalosporin. So when are you giving paropenem, you are not giving something which is an oral counterpart of meropenem, but you are giving something like cefuroxime. So paropenem cannot be considered as a step down drug for meropenem. If it is susceptible to meropenem, we will have to give meropenem. Paropenem cannot be its option. Then other drugs like piperacillin tazobactam, cefoperazone sulbactam, cefepime can work, and if you are lucky, sometimes even levofloxacin and ciprofloxacin also can be susceptible. So they excellently go into the ear cavity and work very well. So if the quinolones are available as an option in the culture report, you can go for it. And some people favor hyperbaric oxygen therapy. For this condition, generally 4 to 6 weeks treatment is going to be required, and 1 or 2 weeks treatment is not going to be easy, and most of it is going to be systemic antibiotics. I think Dr. Sima, I will finish over here. There are a few slides remaining, but we can discuss them later. Thank you.
Thank you, Bharat. Thank you very much, and thank you for keeping the time. I think Dr. Vaishali can take over now.
Thank you, sir. Thank you.
Thank you, sir. So we move on to our second session, that is strategy to improve surgical outcomes of face in CRS. And I invite Dr. Samir Bhargav to come and chair the session. So Dr. Samir Bhargav is Professor ENT in HBT Medical College, Mumbai, and consultant at Hinduja Healthcare Hospital and Dr. Orient Cooper Hospital, Mumbai. He has conducted several live surgical workshops all over the country since 1996 and has been a guest speaker and panelist at several conferences and workshops. He has delivered the prestigious Dr. Ramesh Sanjgiri oration at Goa in 2015 and Dr. S.N. Cooper oration at Maharashtra Ophthalmic Conference in 2016. He is a co-author of a short textbook of ENT diseases which has been read by more than 2 lakh students. He has several papers and chapters in national and international journals. I hand over session to him.
Good afternoon, everybody. Oh, it's almost evening. So, continuing with our academic session, we've had one excellent lecture so far. The speaker for the second lecture is Professor Dr. Dwaipan Mukherjee. He is a leading ENT surgeon from Kolkata, and he is the professor at the KPC Medical College and Hospital. He is presently the Associate Secretary of the Association of Otolaryngologists of India. He has been the past Secretary of Association of Otolaryngologists of West Bengal, from West Bengal, and we have all seen him in a very dynamic role last year as the Organizing Secretary of the AOI 2017 at Kolkata. He has received the prestigious Major K.K. Ghosh Award and the prestigious Professor Shantanu Banerjee Award for presenting the best operative video in the state conference in Siliguri. He is ever smiling, has an infectious smile, and today he is going to be talking on the strategies to improve surgical outcomes of FES in chronic rhinosinusitis. Please bring your hands together for my dear friend Dr. Dwaipan Mukherjee.
Good evening, everybody. First of all, I'd like to thank CIPLA Inspira and Dr. Simap Sheikh for inviting me in this Orient. It's a great initiative by CIPLA, and I think in coming days it will be a full-fledged ENT conference. This is nice to have Dr. Samir Bhargav as the chairperson of this session, one of the finest face surgeons of our country with vast experience, and thanks for kind introduction, and most likely we will have some good inputs from him also. Now, in our day-to-day practice, all over the country, the ENT surgeons are doing face for different types of chronic rhinosinusitis, starting from simple chronic rhinosinusitis to extensive polyposis or for the fungal sinusitis. But in all those cases, at least for some cases, we cannot match the expectation of the patients. So sometimes some simple strategy or just a little bit twist in the strategy may ultimately ensure positive outcome of those patients. Now, as we all know, chronic rhinosinusitis is basically progressive inflammatory disease, and medical therapy forms the mainstay of the management of CRS. But if the medical management fails off or there are some complications, we used to do functional endoscopic sinus surgery. But functional endoscopic sinus surgery is not the curative answer for CRS. It has only adjunctive role to the medical therapy. So, if we cannot answer the CRS with face, why we should go for functional endoscopic sinus surgery? But it has some definite advantage and adjunctive role. First, by removing bulk of the inflammatory tissues from the nasal cavity, we are reducing the load of inflammation and the nasal cavity will be patent, so the quality of the life will be improved. Second, by removing all the polyps and inflammatory tissues from the sinuses, basically we are re-establishing the ventilation and drainage of the sinuses. And third, last but not the least, by removing all those polyps and inflammatory tissues, we are basically ensuring better penetration of the topical medical therapy into the target area, that is the sinuses. So, for these purposes, in selective cases, after proper medical therapy, we should go for functional endoscopic sinus surgery for better outcome. Now, what are the goals for face in CRS? It obviously improves the quality of the life. There are different types of problems in CRS, but one symptom, that is anosmia, can be improved a lot by doing functional endoscopic sinus surgery. Why? Because if there is bulk amount of inflammatory tissues or polyps are present just medial to the middle turbinate, then topical medical therapy is not beneficial because it cannot reach this inaccessible area. So, by removing all the polyps and inflammatory tissues from that part, it is obviously beneficial, and postoperatively all the topical medical therapy can reach this inaccessible part. So, there is a lot of improvement in this aspect. So, by doing face, we can improve the olfaction quite a lot. Now, face reduces the incidence of asthma and has beneficial effect on pre-existing asthma. Actually, by removing all the inflammatory tissues, the lower respiratory tract are basically exposed to less amount of antigen. So, it is obviously beneficial, and in selected cases, early intervention and continuous follow-up reduces the chance of recurrence and revision rates. Now, we come to the one of the very important part, that is the patient selection. Patients with severe symptoms persisting even after adequate medical therapy are the ideal candidates for face, because this group of patients are actually earning the surgery and we are not imposing surgery on them. So, most likely this group of patients are the most satisfied patients post-operatively. So, these are the ideal candidate for face. And when at the time of endoscopic examination, we can find this type of thing like extensive polyposis or thick pus coming out from the sinuses, obviously we should not waste much time and we should go for functional endoscopic sinus surgery. And if there is fungus, that is fungal debris or thick mucin present in the sinuses, obviously we should go for functional endoscopic sinus surgery as early as possible. Prior to the operation, CT scan is mandatory, and even after adequate medical therapy, if the picture is like this, complete blockage of the osteometal complex and multiple sinus disease, we should go for functional endoscopic sinus surgery for better outcome. And if like this, double density in the sinuses, obviously it's a case of fungal sinusitis. In those cases also, after adequate medical therapy, we should go for functional endoscopic sinus surgery as early as possible for better outcome. But in these cases with limited disease, when there is other associated endoscopic operations. But we should keep one thing in mind, we should read the CT scan very cautiously prior to the surgery, because this is ultimately roadmap of a face surgeon. Now we come to the preoperative management. Antibiotic therapy is one of the very important part of preoperative management. We can use coamoxiclav, macrolides, fluoroquinolones and so on, but advising macrolides, specifically azithromycin or clarithromycin, at least 4 weeks prior to the surgery is always beneficial, because it has already proven that this will cause less chance of recurrence. This is not due to antibiotic effect, but this is due to anti-inflammatory effect of the macrolides. We can advise preoperative systemic steroids for 5 to 7 days, prednisolone 0.5 to 1 milligram per kg per day. Obviously this will reduce the size of the polyp and there is less chance of bleeding at the time of surgery. So better visualization, that means better quality of the surgery. Nasal topical steroid spray, I usually prefer to advise nasal spray prior to the surgery. In limited disease, it can do wonder. But in extensive polyposis cases also, I always prescribe nasal steroid spray prior to the surgery, because it will create a habit to the patient to take this drug, and that ultimately have some beneficial effect postoperatively to continue with this nasal steroid spray. Management of the coexisting illness is very important. One of the most important thing is hypertension. We should correct hypertension prior to the surgery. Obviously beta blockers are preferable, because it not only reduces the blood pressure but also reduces the pulse rate and ultimately leads to less perioperative bleeding. Diabetes should be controlled prior to the surgery, and if we are dealing with diabetes, then we should control the dose of the steroids preoperatively. If coexisting allergic rhinitis are present, then allergic skin prick test can be done, and after identifying the specific allergen, we can go for immunotherapy. And if we are dealing with immunocompromised patients, then we should rule out invasive fungal sinusitis. Now we come to the very important part, that is the patient counseling. We should explain the patient that the medical management is the mainstay of therapy for CRS, but face has some adjunctive role. And we should explain the expected benefits and expected complications. And proper counseling of the patient and patient parties regarding the importance of adherence to postoperative follow-up is very important for surgical outcome. But the most important thing is appropriate management of the expectation of the patient. Because in this era of litigation, this thing is very important, appropriate management of the expectation of the patient. So for face, this part of the counseling is very important. Now we come to the anesthesia. In all the extensive cases, obviously we will prefer hypotensive general anesthesia, but in those cases, we should advise our anesthetist colleagues that they should not use GTN, because this is the commonest drug used in operative theatre, because by using GTN, the pulse rate will be increased, so there is more chance of diffuse bleeding at the time of surgery, so there is every chance of complication. So instead, they can use esmolol or other beta blockers. Those drugs can reduce the pulse rate, so there is less chance of diffuse bleeding at the time of surgery. Position of the patient, 30-degree head up is always beneficial to reduce the amount of bleeding, and we should give decongestant nasal pack prior to the surgery at least for 15 minutes, and we should not injure the normal mucosa at the time of giving nasal packing. Now we come to the basic steps of FACE, uncinectomy. This is the first step of functional endoscopic sinus surgery. But before going to uncinectomy, we must palpate the uncinate and try to know what is the upper attachment of the uncinate. Because if the uncinate is attached laterally, that means we are dealing with a very narrow infundibulum. So at the time of uncinectomy, we may inadvertently injure the eye. So the upper attachment of the uncinate is very important, and we should recognize the upper attachment prior to the uncinectomy. And removal of the lower part, that is the horizontal part of the uncinate, is very important. There are several types of instruments available for uncinectomy. This is with very old instrument, that is sickle knife. We can incise entire uncinate from the upper part to lower part by using sickle knife. But some important tricks are always beneficial, because we should preserve the mucosa in this region. So when we are trying to remove this incised uncinate with flex sleeve, the rotation of the forceps should be anti-clockwise, so that there is no injury of the mucosa in this part. Simultaneously, we should remove the lower part of the uncinate also, and in this time we should rotate our forceps clockwise to prevent any injury to the normal mucosa. So by doing this conventional uncinectomy, we can ensure better outcome. Sometimes the uncinate are polypoid like this. In those cases, this is obviously beneficial to use the microdebrider, but in those cases we should keep the face of the blade towards the lateral wall, otherwise we can inadvertently injure this part of the middle turbinate and ultimately leads to postoperative adhesion formation. So these small things can ensure better outcome, and we should remove this horizontal part of the uncinate totally, because if there is some part left behind, that will cause recurrence of the disease and ultimately leads to obstruction of the middle meatal antrostomy. So complete removal of the lower part of the uncinate is of utmost importance. Now we come to the next step, middle meatal antrostomy. Adequate widening of the maxillary ostium and preserving of the healthy mucosa around the ostium is very important. But there are some confusions regarding the size of the ostium. As we all know that nitric oxide is very important for proper mucociliary clearance. So at least for simple chronic rhinosinusitis or in polyps cases, we can go for moderate size middle meatal antrostomy, and by doing that we can ensure the availability of nitric oxide and better postoperative healing and better mucociliary clearance. But in cases of fungal sinusitis, we obviously need a big middle meatal antrostomy for the purpose of clearing. But in some cases, if there is extensive polyposis, sometimes it is very difficult sometimes it is very difficult to identify the middle meatal opening, the maxillary sinus opening. So in those cases, we can use the curved suction tip, and we can just follow the upper margin of the inferior turbinate, and automatically the tip of the curved suction will enter into the maxillary sinus, and with some gentle push we can enlarge the opening, and then this part of the tissue can be removed by using microdebrider. But by doing this, we can ensure there should not be any inadvertent injury or entering into the eye. If accessory ostia is present, like in these cases, we should communicate the natural ostium with the accessory ostium by removing this part of the tissue. Because if we cannot join the natural ostium with the accessory ostium, then there is every chance of recyclation of the secretion post-operatively. So it is always beneficial to enlarge the natural ostium of the maxillary ostium in expense of accessory ostium. So we can remove the tissues in between and ultimately leads to better surgical outcome. Sometimes the entire maxillary sinus ostium is occupied by polyped and thick mucosa. So in those cases, obviously microdebrider is preferable, and by using microdebrider we can remove all the polyps and thick mucosa, and we can ensure a smooth margin, and we can avoid raw bone. So by ensuring smooth margin and avoiding exposure of raw bone, obviously our surgical outcome will be much better. Now, opening up all the air cells, I will not take much time for the ethmoidectomy, but one point should be keep in mind that when we are going inside, that is from the anterior ethmoids to posterior ethmoids, we should perforate the basal lamella inferomedially, because by doing that we can avoid inadvertent injury to the important structures available in the lateral wall of the ethmoid. So it is always better to enter with inferomedial direction. Coming to the sphenoid sinus, if there is limited disease and the vertical part of the middle turbinate is malleable, then we can use this approach for the limited disease, and we can remove all the thick mucosa and the polyps in this region. This region is basically inaccessible, but we can remove the polypoid superior turbinate or the polyps in this region by microdebrider. But one point should be keep in mind that at the time of enlarging the ostium of the sphenoid sinus, we should start from the inferomedial end like this. So by enlarging the sphenoid sinus in the inferomedial direction, basically we are staying away from the vital structures, that is the optic nerve and internal carotid artery in the lateral wall. So there is less chance of complications. I am skipping the frontal sinus because Dr. Samir Bharga has an entire session on frontal sinus. Now we come to the middle turbinate. After a very good face surgery, if the picture is like this, totally lateralized middle turbinate, then all our good work will go in vain. So we should avoid this situation, and if we are suspecting a destabilized vertical part of the middle turbinate, obviously we should go for vulgarization or suturing. So we can suture the vertical part of the middle turbinate with the nasal septum. But when we are doing face, we should try our level best to preserve the horizontal part of the middle turbinate, because if we can inadvertently remove the horizontal part, obviously the vertical part will be destabilized and can fall in the lateral wall. Now we come to the postoperative care. Nasal irrigation, this is very important. We have different types of nasal saline solution, but we have ready-made alkaline nasal wash. After doing face, actually there are some injuries to the nasal mucosa, so pH of the nasal cavity will be reduced. So there is chance of secondary bacterial infection. So alkaline nasal wash is always beneficial to remove all the crusts, and it will also increase the pH of the nasal cavity, so there is less chance of secondary bacterial infection. Aggressive sinus cavity debridement in the postoperative period can be avoided because it will cause more damage of the mucosa, but at the time of postoperative visit, gentle clearing of the thick secretions and removal of the crusts are always beneficial, because this will ensure early healing. We can start postoperative nasal steroid spray. It reduces the symptoms and it will prevent further recurrence, and systemic bioavailability of all these nasal steroid sprays are very limited. So there is very little chance of complications. So we should start steroid nasal spray postoperatively after 5 to 7 days. Other treatments like antibiotic, oral steroid, antihistaminics and leukotriene inhibitors can be used in selective cases. So the take-home messages are CRS is a progressive disease and mainstay of the treatment is medical therapy. Face opens up the drainage pathways and sinuses are opened up for effective postoperative irrigation and application of topical corticosteroid nasal spray. Face reduces the symptoms and improves the quality of the life and olfaction. Opening all the ear cells and also preserving the healthy mucosa are the goals of the face. Simple surgical steps can improve the outcome of face, and postoperative care is very important for better outcome of face. Thank you for patience hearing. So I have 3 questions for the audience. You can vote for this. What is your preferred choice of preoperative antibiotic in CRS? Coamoxiclav, macrolides and fluoroquinolones. Your time starts now. Coamoxiclav. Okay. So what is your preferred choice of postoperative irrigation? Normal saline, hypotonic saline, hypertonic saline and alkaline nasal wash. Alkaline nasal wash. What is your preferred duration of nasal steroid spray post-face in CRS? 3 months, 6 months, 12 months, lifelong? Variable response. So, thank you for patience hearing.
Thank you, Dr. Dwaipan. That was an excellent talk, and at the end you really summarized that it's not just a surgical kind of access disease, it's also the medical part which is equally important, and your questions were essentially based on the fact that we need to remember that medical line of treatment is equally important in this condition. Any questions can we invite now, or is it later? I'll just like to ask you one question. Since you emphasize so much on the nasal irrigation, so do you counsel your patients as to what exactly, how should they go about doing the nasal wash? Is there a particular position that you would ask them to do, or is just standard, take a syringe and douche the nose?
Nasal wash?
Yeah.
So it is, I always prefer to start nasal wash as early as possible after removal of the pack. That means 3 to 4 days post-operatively. and I always used to teach the patient the exact positioning of the nasal wash, and nowadays ready-made alkaline nasal wash is available, so it is very useful for all the patients, and it is always advisable to use at least twice in a day for 3 to 4 weeks.
Thank you.
Thank you.
Thank you, sir. So we move on to our third session, that is juvenile nasopharyngeal angiofibroma, and I invite Dr. M.K. Rajsekar and Dr. Anthony Irudayarajan to come and chair the session. Dr. M.K. Rajsekar is a leading ENT otorhinolaryngologist from Chennai and has an experience of 26 years in this field. At present, he is professor and head of the Department of ENT at Sri Balaji Medical College, Chennai. He was former director and professor of ENT, Madras Medical College, Chennai. Dr. Anthony is a chief ENT surgeon at Dr. Anthony's Endoscopic ENT Center, Chennai. He is also professor of ENT head and neck surgery at Madras Medical College, Chennai. He has over 25 years of clinical experience, and his special interests are in endoscopic stapedectomy, sleep apnea surgeries, and pituitary surgeries. I hand over session to both the chairpersons.
Thank you. I invite Dr. Janaki Raman to deliver a lecture on juvenile nasopharyngeal angiofibroma. Janaki Raman needs no introduction. He is a well-known figure in ENT in India. But anyway, I have to introduce him. Dr. T.N. Janaki Raman is a managing director of Royal Pearl Hospital, has done his graduation and post-graduation from Madras Medical College. He was the best outgoing student in both MS and DLO and was awarded a Cherry and Gold Medal for his excellent ENT work by the Chief Minister of Tamil Nadu. He has been awarded Young Indian Scientist 2008 by the Chief Justice of Tamil Nadu State. He has been pioneering various ENT surgeries in the part of India for the past 11 years. He has vast experience of doing more than 2,000 mastoid surgeries, 1,000 endoscopic sinus surgeries, around 600 stapedectomies, tonsillectomy, laser surgeries, micrological surgeries, and surgery for OSAs. He has trained more than 30 resident ENT surgeons by offering them a one-year fellowship course. He has also released an e-book and video book in rhinology, which is very popular among postgraduates in medical colleges around the world. Another one thing, he has acted, this is not mentioned here, he has acted 3 Tamil movies as a hero, and he is a best singer, and he is a good badminton player, and more than that, he has written a book in nasal angiofibroma. It's a textbook of nasal angiofibroma. It's a well-known, internationally well-known book. Okay, Janaki, you can continue. You can start your...
More than that, he has started as a MBBS student in Madras Medical College. Then there he did his DLO and MS, and has become an ENT surgeon. But now he has become a neurosurgeon, and more than that, tomorrow he is going to be an examiner for neurosurgery in Nepal. So we always say that we don't cross dura or arachnoid, but he is a full-fledged neurosurgeon. The Madras Medical College is very proud to say that he is our product, and I am so happy to say he is my MBBS, DLO, and MS classmate.
Thank you. Thank you. Good evening, everybody. So, first of all, thank you for the nice words, Mr. Moderator. I first of all thank Professor Seema Sheikh for having invited me here for this very prestigious event held by CIPLA. Thank you very much. And I should really thank my teacher, Professor M.K. Rajsekar. I am not sure if so many have heard him actually giving lectures. To me, he is the best teacher I have ever met. So I really thank you for making me what I am today. So another important character who is sitting there is Professor Anthony, and I call him the encyclopedia of ENT. You know why? Because whenever I have a doubt, immediately I'll phone up and ask him, can I do this? And he just spontaneously answers because he knows, is read so well read. So thank you for moderating the session. So with a kind permission of the moderators, what I'm going to do, my lecture is around 1 hour. They've given me 1 hour for JNA. I'm going to split it into 40 minutes. So I'm just going to talk for 40 minutes, and 20 minutes I'm going to give it to the audience. So we're going to be very interactive, and you can ask me or say or comment and do whatever you want in that 20 minutes. Okay? Let's make it like that. Is it okay, Mr. Moderator?
Okay.
Perfect. So first of all, I want to dedicate this presentation to my teachers. So I always say teacher, teacher, because I always believe that teaching is the most noble profession on this earth. So I thank Professor Amin Kassam, Professor Karao, and of course Dr. Daniel Prividello. My concept of JNA, actually I started this, doing JNA in the year 1999. So that was the first JNA I did. And from then onwards, till 2006, I was not very good in concepts of JNA. But they gave me concepts on skull-based surgery, and I applied that concept of skull-based surgery into the surgery of JNA. And so I modified my whole concept of operating on a JNA, and that credit goes to none other than these three people. So I dedicate this to them. So I also thank CIPLA Orient, because this is being seen all over the world. So I can understand that there are so many people who are seeing this, a very good academic endeavor. And of course, I'm the academic head of neuroendoscopy, Karl Storz, Asia Pacific. Well, JNA. So we're going to talk about endoscopic approach to not JNA. So now, if you go to various conferences abroad, they have taken off nasopharyngeal, and we just call it JA. So that is the current terminology. The reason is because it is not arising from the nasopharynx. It was thought to be arising from the nasopharynx. So now the term JNA is out. And if you see the recent literature, it is just JA. So we call it JA, juvenile angiofibroma. So because this is the current terminology. Of course, I have the privilege of being a neuro head in Vietnam, Davao, and of course, now tomorrow I'm conducting an exam for neurosurgery fellows by ACNS. I think Dr. Ayap is watching me, and this has been headed by the ACNS group and Professor Yako Kato from Japan, who is the neurosurgeon who is actually moderating the whole thing. Okay, now, how is your JNA surgery going to be? You're all JNA surgeons. I know you're going to sit in this audience. In Goa, who will listen to JNA? I can understand your plight, but the very fact that you're sitting there means that every one of you is doing JNA. And if you want to do JNA, how do you do it? Now, this is how I will do my JNA. I want sound. The first is anatomy. Rise the volume. So your anatomy, sound de do bhai. So that's the surgeon, and that's the JNA. And that's how you pick up the JNA. Wherever it is, your anatomy should be perfect. And that's the first criteria for you to be a JNA surgeon. The second criteria is you should be extremely focused on anatomical structures. And how do you focus? That is the target. You see how you get into the target? This is how you get into the target. So you should be so focused on JNA that your focus cannot deviate. And that's how you really become a good JNA surgeon. And the third most important thing I believe in JNA surgery is the technique. So every surgery needs a technique. And if you are not good at that technique, the surgery is not good. And this is how I feel you should be a JNA surgeon. So you see that by pure technique, you can make an average UMG surgeon, an average JNA surgeon, into a fantastic JNA surgeon. So that's actually what I want every JNA surgeon to be. Anatomy, precision, and technique. So this is the three important features of a good JNA surgeon. Well, let's go on. So how did I really form this concept? Because this was not there before. Before I published this, nobody had published it. So this is the first publication which we made. We have now around 12 to 13 publications just on JNA. We are making 4 publications more. So we found that the smallest JNA, we had 6 cases. I really thank all the people who really referred all these cases. The 6 JNAs which were not nasopharyngeal at all. There is no nasopharyngeal component. It is just from the pterygoid wedge. Then is where I decided this is arising from a place called the pterygoid wedge. So then we studied all our JNAs retrospectively. Around 200 plus JNAs we studied, and most of the JNAs had this pterygoid wedge involvement. And that is how we brought out what is called the Ram-Haran sign. So what is this sign? We compared this width, the width here with the width there. And this was clearly found to be enlarged. And once we studied the parameters with our radiologists, then we published this sign. And you can see in all your JNAs that most of your JNAs will have, you would have read about Hallman-Muller sign. You would have read about Hounder's sign. All these signs are present only in less than 60% of individuals. Whereas if you see this sign, you will have it more than 90% of individuals. You can take your JNAs and retrospectively study. Well, now then we studied all the pathways, how this JNA spreads. Imagine this is the sphenoid sinus, and the sphenoid sinus has got the anterior wall and the lateral wall as the pterygoid plates, both sides pterygoid plates. The pterygoid plates unite to form the pterygoid wedge, and that is where it starts. Now, from the pterygoid wedge, it can easily move on. So how does a JNA spread? Through the pathways of least resistance, correct? Am I right? That's what is written. To me, it's wrong. So that is where when I studied JNA, I said, why are we following like this? It is wrong. Because if it follows the pathway of least resistance, where should it go from the sphenoid or the nasopharynx? Nasopharynx, which is the pathway of least resistance? Oropharynx. It should go from the oropharynx into the laryngopharynx. But I have never seen a single JNA going into the laryngopharynx. So why should we follow the West, who have got just 13 and 12 cases? Then I started studying, how does this spread? So when we started studying it, it then has a spread apart from the pathway of least resistance along the submucosal vessels. Well, then we started thinking, how does it spread? So number one, pterygoid wedge, pathway of least resistance, sphenoid sinus, pathway of least resistance, nasopharynx. From the nasopharynx, it doesn't go down. It holds along the posterior septal branch of the sphenopalatine artery. So the posterior septal branch is there. That is the artery. So it catches hold of the artery and goes there. And once it goes there, it sees a pathway of least resistance. What is the pathway of least resistance? The sphenopalatine foramen. So it sees the sphenopalatine foramen, and then it moves into the sphenopalatine foramen, into the pterygopalatine fossa. It is a beautiful tumor. If you understand this tumor, it's simply fantastic to operate on this case. Now, from the pterygopalatine fossa, you have the IMAX. It goes through the IMAX, and it goes into the pterygomaxillary fissure and goes into the infratemporal fossa. From the infratemporal fossa, where can it go? It can go with the pathway of least resistance or the vessels. It can go into the cheek, or it can go to the temporal fossa. It is so easy to understand this. And then from there, if it goes, it has occupied all these areas. Then from there, where will it go? It will see upwards into the orbit. And in the orbit, what does it do? It goes through the inferior orbital fissure into the orbit. And inferior orbital fissure is the anterior boundary of the superior orbital fissure. So it goes into the superior orbital fissure. Superior orbital fissure is the anterior boundary of the cavernous sinus. That is how it spreads into the cavernous sinus. Now, imagine this JNA is starting from the pterygoid wedge. It moves like this, it moves like this, it goes like this, it goes like this, it goes like this. And this is what is called, I named it as the anterolateral spread. So this is how I came to the concept of this JNA moving anteriorly and coming laterally, and this spread, we named it as the anterolateral spread. Well, then the JNA is not being removed by the doctor. What will it do? It will start growing further, but it doesn't have space to grow, so it grows posteriorly. That is where it starts spreading posteriorly. What is the pathway there? The pathway is the cancellous bones of the greater wing of sphenoid. And that, it goes, where does it lead to? It leads on to the Meckel's cave. It leads on to the Meckel's cave. And that is the quadrangular space. So it goes to the quadrangular space, it goes to the Meckel's cave between the paraclival carotid and the horizontal carotid, and then it spreads. It respects the dura. Most of the cases it respects the dura, but I'm going to show you so many cases where it has entered into the dura, into the brain. So this is the main core of this lecture which I'm going to give you. So how does JNA enter into the intracranial cavity? So this is what we're going to discuss today. So this is what we actually did of our 241 cases. Now we have done more than around 300 plus cases of JNA, and then we formed the staging system, and then of course we published it in the SNI. So what is the, many people ask me, why did you bring a staging system? I said, if you take generally the JNA surgeons, what they do is they use either cautery or a bipolar or a cobblator. These are the three equipments which they use, and just like that they start, either using the diathermy over it, or they use bipolar over it, or the cobblator over it. Even yesterday I did a JNA. I did 2 JNAs yesterday. If you see me doing a JNA, I hardly use coblation. I hardly use diathermy. I hardly use bipolar. Because I feel if you understand the root, you don't need to use anything. The blood loss is less than 20 ml. Our blood loss statistics, according to the world, we had a debate in European Congress, was the least among the world giants of JNA. So what I'm telling you is this is what we published, and this is the staging system which we actually follow even now when I ask my residents to stage. So let us see, that's stage A. So I'm going to illustrate that for you. So this is the pterygoid wedge. It goes into the sphenoid sinus, that is stage 1. So then, again, you can say stage 1B. So you can ask me, why are you, what is the difference? What difference does it make? You're just having just stage 1, stage 1A, 1B. Yes, it makes a difference. Because if you want to tackle JNA in the sphenoid sinus, you have to attack it by removing the posterior end of the inferior turbinate. So I just brought in one step extra for every stage which progresses. So if you look at my JNA surgery, it is almost like mathematics. It's like 1, 2, 3, 4, 5, 5th step, it's out. So it is like that. So you're going to see how we're going to tackle these stages. Stage 1B is like this, and then stage 2A is into the pterygopalatine fossa, stage 2B is into the infratemporal fossa, stage 2C is into the cheek or into the inferior orbital fissure, and then comes stage 3, which is in the quadrangular space, that's the posterior spread. From stage 3, it is all posterior spread. And then it is in the cavernous sinus, you can see that. And then comes 2 difficult areas to treat. Number 1 is the lower parapharyngeal space. If you have lower parapharyngeal space involvement, it becomes difficult to operate on a JNA. So endoscopically, this is all endoscopic classification. And if you see this 4B, it's going intracranial, it's going into the brain. So how do you deal with this? And then I got a stage called stage 5, where you have to do an external approach. So this is how we classify it, and for each stage we have steps, specific steps to do it. So I've seen many surgeons, actually what they do is they just do endoscopic modified Denkers for all the cases. It is not required. It is absolutely not required. It's just an overkill for a small JNA. Because if it's going to involve the pterygopalatine fossa, you don't need to do that. So we brought in a lot of steps. Now let us start our surgical videos. Now this is a stage 1A video. Now what will be the first step? If you read my book, you can clearly see a wide middle meatal antrostomy, and then you can see anterior posterior ethmoidectomy. You can see that beautiful tumor with a capsule there, that's a shell of the bone, and then you see we are removing, that's a superior turbinate, that's a middle turbinate, and then you remove this piece of bone. And then what we do is what is the blood supply for this JNA? It's the posterior septal branch. You just coagulate the posterior septal branch, this JNA dies. It's a dead snake. And then you can just pull it out. But please understand that we brought in a very important thing, which is even now followed in all around the world, that is drilling of the pterygoid wedge. So we drill the pterygoid wedge, see the median nerve in every case, and then you can see that's the median, that's the V2, that's lateral recess. So that is the complete excision. Unless you drill the pterygoid wedge, you will get a recurrence. This is for sure. So this is something which I want to emphasize, and that's the important carry-home message. And always, 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 please, if you do a JNA, take a post-op 36-hour CT scan with contrast. And this is something which I hardly see in many people, because they postpone it to 3 months or 6 months. This is something wrong. You can't do this for sinusitis, because in sinusitis you'll find residue, but in JNA you will find that JNA back. So it is not a recurrence, it is a residue. So what is the difference between a residue and a recurrence in JNA? 36-hour post-op scan is the hairline difference. If you say your 36 hours post-op scan is normal, and then the patient has again a JNA after 3 months or 6 months, this is a recurrence and not a residue. This is how we differentiate between recurrence and residue in JNAs. Now let us see a 3A. 3A, I told you, is involving the, just have a look at it, how it's involving the superior orbital fissure. This is the scan. I always read only the scan. I don't have MRI into my account at all. That's superior orbital fissure and anterior wall of the cavernous sinus. That's the anterior clinoid process. The cavernous sinus starts from the anterior clinoid process. We always do four-handed surgery for JNA. You can see that I'm doing a modified endoscopic Denkers, and you see that that's the nasolacrimal duct. We transect the nasolacrimal duct, and in fact, we talk about Daniel Simmons, we talk so often. He says you could have just translocated the duct, but to me there's no difference. That's the IMAX. You can see the IMAX, and I clip the IMAX there, and once I clip the IMAX, you see that that's the temporalis and the lateral pterygoid. And then what we do is, this is very important, to drill the medial wall of the orbit, and you see that V2. So always try to preserve the V2 in JNAs. This is something which is very important, because sometimes the patient will come and say, numbness, I have numbness here after your surgery. So that's because so that's the anterior wall of the cavernous sinus. You can see that that's a meningeal layer of dura. You can see all the cranial nerves going to the superior orbital fissure. I'm using a carotid Doppler to check whether that's a carotid artery, and yes, you get the carotid artery pulsations. We keep Surgicel, and then finally don't forget to do the pterygoid wedge drilling. So once you do that, then this is a complete excision of a JNA. So this is how we do what is called the centripetal approach. That is, don't touch the JNA, and you go around the JNA, and then finally attack the JNA, and after you get controls of the JNA. So that's about stage 3A. Now, coming to stage 3B, this I operated in Malaysia. This is a 9th revision. 9th revision, operated by so many stalwarts, not to mention any names. This was completely engulfing the carotid. This was the carotid artery right in the center of the JNA. And imagine you're operating in a different country, and this is a case given to you for surgery. And this is how we did this case. You can see that. Now that's actually, there's so many coiling had been done. So that they're all the coiling which was done. So that was the theater setup in the country. This is you can see that, and we are doing the four-handed technique. So infratemporal fossa has got 5 levels. Please understand there are 5 levels of infratemporal fossa. You should know at what level you're dissecting in the infratemporal fossa, because this is called the level 4 infratemporal fossa dissection. And then you see what I'm doing, that's the Petrus apex. So we are drilling the clivus, that's the clivus. Of course, I've edited that. If you want the presentation, I can give it to you. If you have a pen drive, I can transfer it to you. So that is actually the Petrus apex, and I'm giving Surgiflow, and that's the infralateral trunk. You can see that's the carotid artery. I'm bipolarizing the infralateral trunk. So there are 2 branches of the cavernous carotid. One is the meningohypophyseal trunk, and second is the infralateral trunk. So that's the infralateral trunk. And what we always do in a JNA involving the carotid is that we get proximal control and distal control. So I get a paraclival artery, paraclival carotid control here proximally, and I get a supraclinoid carotid distally. So even if there is an eventuality, I can go in for a carotid sacrifice. So you can see that now I'm trying to strip the JNA, and in fact, see that's a carotid artery. You can see that carotid artery pulsating. See that? And now I'm stripping the JNA right from that carotid. You can ask me, how can you do it from the carotid? If the carotid ruptures, what happens? Please understand that the carotid is not directly involved by a JNA. There is an endosteal layer over which the JNA will be sitting. So you can peel the JNA from the carotid. This is a very important carry-home message for everybody dealing with carotid involvement of JNA. Now, let us go to stage 4A. Again, this was another publication by us in the International Journal of Otolaryngology, a European journal. Now imagine this JNA. It is going down. It is going right till the tonsillar fossa. You can see here, it's going right till the tonsillar fossa. How will you do it endoscopic? How do you do it endoscopic? So this is where I learned this technique from Professor Castelnuovo. He is one of the genius surgeons I have seen. So I learned multi-port technique, and we published this again. You can see that that is the tonsil, that's the uvula. So I'm making an incision. This is the first reported case in world literature of multi-port technique, and you can see that this is the tonsil, the anterior pillar, and you're operating between the superior constrictor and the medial pterygoid muscle, and then you can actually take the JNA gently and dissect it. And once you dissect it, what you will do, that's actually called the multi-port transoral approach to JNA. So you can approach the skull base through the oral cavity. These are all the current concepts of skull base. So what you're doing now is trying to get that JNA and then bring it, that's the foramen ovale region. Of course, an edited version might not give you a complete, but I can't post the whole video. So what I'm trying to do is to transect the JNA at the level of the foramen ovale. You see, I'm not using any cautery, nothing. I'm just cutting it with the scissors. I generally cut it with the scissors, and once you devascularize it, it doesn't bleed much. And then I'm pulling that into the nose. So the one which was in the tonsil is being pulled into the nose. So I'm delivering that JNA through the nasal cavity. You can see that that's coming out through the nasal cavity. These are all Indian JNAs. When I show it abroad, they even say that, oh my God, we don't see such JNAs at all. But yes, in India, we see a lot of them, a lot of advanced tumors. Now let us see, that's a postoperative scan showing complete removal. Stage 4B. Now, this again we published, the first ever reported in literature. You can see that this is the JNA involving the brain. So how do you deal with it endoscopically? So that's the tentorial branch of the meningoartificial trunk, and what we did, what is again called the multi-port approach. This is the multi-port approach. You can see that this is called transorbital approach. So we have now done 5 cases of transorbital approach. You can see that's a greater wing of sphenoid, and that's a port just lateral to the superior orbital fissure. So you get the superior orbital fissure, that's the dura of the middle cranial fossa, and then what we do is I incise the dura, and that's a tumor right in the temporal fossa. We use it for sphenoid-bearing meningiomas, arachnoid cysts of the temporal lobe, and all these things. Now we now trying to do microdissection and removing the tumor from the temporal fossa. I'm using cautery here, of course, because inside the brain we don't want any bleeding, and you can see that we are now trying to deliver this and the JNA out of the brain. And that's CSF leak after removal, and then you can see the post-op MRI showing a small residue here, because that was actually the tentorial branch. I transected it, and it was gamma knifed. So I sent it for a gamma knife later. This is the boy. You can see that the eye is moving, lateral rectus not involved. This is the only incision we used. There is nothing else we used for the boy. Okay, so we published all this. So now what next? What next to do in JNA? What's the next step? So then we thought we have to do something which is involving the carotid completely. So this is under publication. So we are going to publish this. These are the first 4 cases reported in literature. So now will be reported. We are just making papers out of it. So if it is engulfing the ICA, so imagine this is going to be the JNA. So the JNA going into the temporal fossa, totally into the temporal fossa. Can we do it endoscopic? Yes, we can do it endoscopic. Now let us see how we do it. You see, that's what we did. So this JNA, this is the ICA, cavernous ICA, JNA here and JNA here. So if I go endoscopic or from external approach, you're going to avulse the ICA and he's going to bleed to death. So what we did, we started thinking of 2 things, which Mario Sana, I'm sure everybody has heard about Mario Sana. He does stenting of the carotid. So he stents the carotid. So we started trying to explore that option in Trichy, and we have one of the best radiology department in our center. So we ordered for a stent, but we couldn't get a stent for the cavernous carotid. We get stents for clival carotid, paraclival carotid, but we don't get stents which are bent. So what we did was we thought of carotid sacrifice. So what we did was we coiled the carotid. So we are now coiling the carotid. See here, what we do now is That's actually the radiologist who is coiling two parts. One is paraclival, the petrous part and the supraclinoidal part. And this carotid I can cut like this. I can cut this carotid like this, and I remove the tumor along with the carotid artery. So that is what we did in this case. You can see that we resected, and that's the temporal lobe. And of course, this is the post-operative scan. You can see that this patient, you can see the scan, completely resected carotid going into the temporal lobe. This was our first case. The second case was like this. So you can see that this is the tumor inside the temporal lobe, and completely on both sides of the carotid. You can see that this is, so people ask me, have you seen any JNA going intradurally? We have 6 cases now. 6 cases of JNA going, see that intracranial. This is actually ACA and MCA. It's going beyond the ACA MCA territory and involving the carotid going into the temporal lobe. So again, what we did, we now got a neurosurgeon to do a pterional approach from this side, and then we did a nasal approach from this side. So we attacked, I removed till the level of the cavernous sinus, and the neurosurgeon removed it. So that, what we did before was mapping the tumor three-dimensionally. This is called the 3D mapping. You can see that now we are trying to map that tumor. Where is this going? Which hole? You can see that's actually the hole. That's a temporal lobe, and you can see that it is going like that. That's a greater wing of sphenoid. This is the tumor. So once we mapped it, we exactly knew where to make the craniotomy. So that's what we did, and then we coiled the carotid. So this is actually the coiling of the carotid. You can see that we are coiling that carotid there. So that's a coil. You can see that coil very clearly. So I can resect the carotid now. So we resected the carotid, and that is actually the video. Of course, I'm not going to play too many videos now. This is actually the pterional approach being done by the neurosurgeon. We have one of the best neurocenters in our place. Trichy is very famous for neurosurgery, and now you can see that this is tumor we have resected completely. This is the carotid completely coiled, and then we resected that tumor completely. And that's a post-operative scan. You can see that complete resection. Even now, the patient comes for follow-up. It's now around 1 year since we have operated, and the patient still comes for follow-up. And now this case 3, you can see that this is actually the tumor going into the brain. This is the carotid. And now, again, we coil the carotid. You can see that we are coiling this carotid here. So that's a coil of the carotid. Can you all see that very clearly? The coil of the carotid. And then we resected the carotid, and that's again the post-operative scan. And now, this is the 4th case we did recently, around 3 weeks back. We did it, and that's actually the tumor going into the brain. And we, sorry. So this is under publication now. So we will be publishing this, and this will be the first in literature again. So now this is the coiling of the carotid being done, and then you see how I dissect that. This is the kind of dissection we do. Absolutely almost bloodless, because we can go around the tumor. That's where it's going intracranial. So what I'll do is I'll segmentally resect this part and then remove it from nasally, that part. Okay, that's a post-operative CT. You can see that this is completely removed. You can see that the temporal lobe is completely exposed. We put a Haddad flap. So now that is the external approach. You can see some tumors. This was referred to me from Kerala, actually. This is a very memorable patient. He lived for around 1.5 years, after which he developed a recurrence. After 1.5 years, he developed a recurrence. But what we did for this case was a Jenica. So Professor Uma, she referred this case. We did a Jenica for this, bilateral maxillotomy, mandibulotomy, and then we removed the tumor. And you can see that that's the second case. I think this is, again, a very interesting case where we operated this case and by the Jenica, and that's a post-operative picture. And so, you can ask me, you're talking just about your, achievements. What about your complications? We have a lot of complications. Please understand that in our center, almost every day, we face some complication because we're doing neurosurgery. So yesterday we had a petroclival meningioma. I operated. There was a small complication. But what I mean to say is every neurosurgery has a little bit of morbidity and some complication. But this is one complication I want to show you, and this is the only complication I had in my 300+ series of JNAs. You can see this patient was referred to me after 9 surgeries, after radiotherapy, And then they said, you operate. I didn't know where the anatomy was. This was a JNA going into the superior orbital fissure. Usually the JNA is covered, I told you, by endosteal layer of dura. So I started resecting this layer. So it was radiotherapy, so absolutely no anatomy. And you see what I'm doing now. I'm trying to cut that endosteal layer. But what happened was that was the carotid. And I had a massive carotid bleed. Of course, even for last week case, I told my assistant, get ready with the thigh. Whenever I go for the carotid, I always say, get ready with the thigh. And then one guy is always sitting there. The moment I say go, he'll make the incision, take quadriceps muscle, crush it and give me. And so what we do is immediate. This was actually managed around 1.5 years back with some cautery. I had to do a carotid sacrifice. Patient developed an MCA infarct. So patient developed an MCA infarct, and in fact the patient died after 18 days. So this JNA was the only mortality we had. After 18 days the patient died. So, but then, to conclude, what is the carry-home message? What is the carry-home message? I want to end it by saying 3 important things. Dr. Tyagi, there's nothing to write. You're just going to see something. So just read this book. It's all there. But the carry-home message is this. Sound, please. This is the first take-home message I want to give you. Don't think you are a best surgeon. Don't preserve the turbinates. Don't touch the middle turbinate. And if you do that, this is what happened to you. So become a clear-cut skull-based surgeon. When you operate on a JNA, you are not a best surgeon. You are a skull-based surgeon. Number 2, get your vascular control. So if you are in doubt, get the neck control. Have a bulldog clamp. Get a bulldog clamp, or else this is what happens. You see that? You will slide and fall when it's bleeding. Have complete knowledge of the ICA. How do you have knowledge of the ICA? It's like the cobra. So in Rajasthan there is a place where they tame the cobra. So you should do something like this for the carotid. Just pull it and play football with the carotid. And if you can do that, then do JNAs with ICA. So this is what I always say, have complete knowledge of JNA and its anatomy before you operate on a JNA. So I think I'm sticking up to time, but it shows time up. I don't know what Professor Mukhtar has done to me. You gave me 1 hour and pushed me into 20 minutes. Thank you very much. Thank you. Thank you. Thank you. Namaste.
Thank you, Janagaram.
I just want only one thing. See, I am very patriotic, and I always believe it's being seen by the world. I know GLAD from, South Africa is seeing me. I know that Indonesians are seeing me. Right now, I am telling you, I am a very patriotic guy. And I feel that there are some tumors which are specific to regions, like JNA or maybe cholesteatomas. I don't know what other fields are. I don't know about it. But then we should be the authority in that. And I think every Indian should have that attitude and do a lot of innovative thought into it. And then we will be there in the world. We will be there. There is no doubt about it. And we all should do it together. Thank you very much. Thank you.
Thank you, Janagiraman. Your mesmerizing talk. So, we actually, Janagiraman, everyone is clapping now. For me, it is not new. 25 years back, his dissertation topic was middle turbinectomy in fist surgery. 25 years back, what was the first stage? That is the early stage of the fist surgery. Just we started fist surgery. That time itself, we selected a topic, middle turbinectomy in fist surgery. Then what he did? During his course, he went to veterinary college where his friend was there. He did turbinectomy in horse, dog, and all animals, and see the skull base. So for me, it is not new. So he is a well-known skull base surgeon. Your hats off, hats off.
Thank you, sir. Thank you, thank you. Actually, I think we should start with comparative anatomy. I always believed that, going to the veterinary college, I in fact even told my son actually this. So when you start with the amphibians and all this stuff, so that you really understand how man has evolved. And once you know exactly where we are, then we know where to go further. Because evolution, you get into evolution, and you don't stay on time. You evolute. So I think every scientist has to evolute. He has to go through evolution. And for that, he should understand all these small creatures and then go on into the next level, maybe gene therapy or stem cell therapy or whatever. But then, unless you understand what a dog is, or a cat is, or a horse is, I did that 25 years back, as my teacher said. So I think everybody, a youngster at least, should start thinking of evolution of mankind. So we can take some questions, moderator, sir?
Yes, you can.
So
Anybody?
it's open for discussion. If you have any
Questions from
queries,
audience?
comments, anything, you can share it. Do we have 10 minutes, Professor? Thank you. You can have the mic, please. Can you give the mic to him?
Come here.
I'm really surprised that you arranged it in Goa and so many people are sitting in Goa. It's really a fantastic achievement. Yeah.
Have you ever operated a GNA in 19 years female?
In what?
Have you ever operated a GNA in 19 years female?
19 years female is something difficult, but in females, I have not operated. I'm yet to see a GNA in a female. There are some reports in literature of GNA in females, but we've had arguments on various stages, like Italy, in London, in America, on what this real tumor which has been reported in the past is, and finally they land up in some other thing. If you do the, markers, I in fact sent you the markers. What are the markers for GNA? So if you do all that, I think maybe you may be right, but if you are right, you will be the first in the world to report it.
Oh,
so,
thank you.
Yeah, you will be the first in the world to report
I
it.
have a case I want to discuss with you. I have a case I want to discuss
Yeah,
with you.
please.
I have a slide.
Yeah. Please. Yeah, Dr. Rajiv, please. It's like a family. Please ask any question. We are ready. We have a discussion here. Dr. Srinivas, you have any question?
Many people are using this cobbleter for debulking of the big angiofibroma.
Yeah.
Do you agree with this thing, or do you appreciate or not?
Yeah, it's a very good question. Actually, using the cobbleter. Yeah, I do it. I do it a lot of times. And you see, you can... My main concern in using diathermy or cobbleter or anything like that, so when you use cobbleter, what happens to the tissue is that the reddish tissue becomes brown or maybe whitish or some other color. So when you're applying it, imagine on the infratemporal fossa. These GNAs, what happens to the GNAs is that they have daughters, granddaughters, and small feet everywhere. They go like small feet. If you see the videos, I can give you any number of videos. They go into the crevices. My only concern is, if you have a big chunk of GNA and you want to resect that into two with a coblation, you can do it. There is no question about it. But when you're operating on its periphery, where it's getting attachment to the upper parapharyngeal space or lower parapharyngeal space or into the cavernous sinus, if you want to use a cobbleter, you might leave behind remnants. So this is what is my concern. And overuse of cobbleter can lead to massive recurrences. So this is my concern. You can use cobbleter on the surface of the GNA. You can cut the GNA. I use a lot of diathermy to cut it into two. This is what is called, we also published it as the principle of segmental resection. This is called principle of segmental resection. So I'm telling you another thing. If you want, Dr. Rajiv, I can give you a video we operated a few days back. Whenever we do the cavernous sinus, if you have a huge GNA and do the cavernous sinus, if you're operating and it starts bleeding, you will not be able to go there. There's no space. So it's better to make it small. So resect it segmentally and make it as small as possible and then go and attack the vital structures. This is very well known. I fully agree with you by using the coagulation to cut the GNA, but not in its periphery. When it's attached somewhere, don't go there and apply the coblation, because you will not differentiate the tissue from the JNA. If it is firm, it's fine, because it's going to come like a ball. If you pull, it's going to come like a ball. There are JNAs, if you pull, they are a little jelly-like, and so a part of it is left behind. And when you use the coblation, what happens is that this part comes out, this part is left behind. So these are potential, So you can also argue that there are papers which show regression, spontaneous regression. We had a big topic in some congress on spontaneous regression of JNA. And some said, why are you going and taking a risk on the cavernous sinus? Why don't you allow it? Please understand, I told them the same psychology. And I'm telling this in front of the world audience. Imagine a tumor which has got blood supply. You have a blood supply and you think in your mind it's going to regress. I think you have to take it with a pinch of salt. It has got its blood supply. If you have maybe a small tumor left only in the parapharyngeal space, everything gone, you have cobblet all around, maybe it can regress. But you can't expect a JNA which is sitting right with a big blood supply and saying that it's going to regress, let us leave it like that. Then I think there's something wrong in the concept of JNA. I think I'm putting my points across right? Okay. Yeah, please, Dr. Handa. Yeah.
How frequent you use?
Can you, I'm a little hard of hearing.
How frequent you use embolization?
Oh, that's a very good question.
Cases?
Beautiful question.
Immediate pre-op.
I understand your question. So this is again a big point of debate. Should we embolize? Should we not embolize a JNA? This is a point of big debate. So the proponents, I'll just tell you the world statistics. You can decide whether you want to embolize or not. Number one, the world proponents for embolization are those who feel that it will lose its blood supply. So when you cut, it's not going to bleed, right? Am I right? That's why you embolize the JNA. Number two, you can embolize only the external carotid artery territories. You cannot embolize internal carotid artery. Am I right?
Yeah.
Correct. Now, if you are going to embolize, the problem is that in 48 hours or 24 hours you take, what happens? You do a double-blind control study of embolized JNA versus non-embolized JNA. If you cut a JNA like that, you cut a JNA like that, you know the trees have got whorls. With the whorls, they find out the age of the tumor. Something like that has been done. The study on a JNA has been done. So the aging of the JNA, the periphery becomes fibrous and the center becomes very vascular. This is how a JNA actually grows, if you look at the pathology. Now, to answer your question, what happens to after embolization is that Professor Schick did a study. He has done a landmark paper. And he says all these granddaughter cysts become very thick. It becomes thick. These granddaughter cysts are not like glomus jugulaire. They actually go into the crevices of the clivus. They go into the crevices of the Haversian system of the bone. The greater wing of sphenoid is filled with Haversian channels. So what happens is that it becomes thick. You do not dissect a JNA. You only give a mild pull. This is how gently we do a JNA. When you pull, if it is, imagine like a jelly, without embolization, it will just come out of that crevice. But if it has become tough, and if the neck is small, all these will remain inside. So Professor Schick confirmed that the incidence of recurrence after embolization is 8% higher than when you do it without embolization. Point number one. Point number two, if you go by a centrifugal approach, that means you attack the JNA and then go inside the JNA, you're going to meet with bleeding. Yeah. Okay? So what we are going to advocate to you is don't touch the JNA. You go around the JNA and then the IMAX supplies it, clip the IMAX. If you have the DPA, SPA supplying it, clip the DPA, SPA. So you do what is called a per-operative ligation of the vessels. The only vessel you cannot ligate per-operatively is the ascending pharyngeal. Apart from that, all the other branches of the IMAX can be ligated. So what except the middle meningeal, of course. So what happens is that what we do is a centripetal approach, clipping all these, and then we remove the tumor. So this is the advantage of doing it without embolization. But to answer your question, imagine a JNA sitting in the cheek. Okay? Now, where will the IMAX be? There are two routes which has been studied. It can go anterior, it can go posterior. We have seen both. We have seen posterior. So what we do is, if it's very vascular there, we just take a bulldog clamp. Just take a bulldog clamp and clamp the ECA, and then after the surgery, release it. Never ligate an ECA, just clamp and release it. That's it. So that's equivalent to your 40,000 or 50,000 embolization. There's nothing big about embolization. So I think this is not a topic which, like, you know, the world discusses, you have to embolize, no embolize. We now embolize the ICA. Now we are talking about stenting of ICAs. So where's the question of embolization of ECAs? Of course, you can do it whatever way you want. If you want to embolize it, do it. But only thing is the incidence of recurrence will be 8% higher in your embolized GNAs.
That's right.
Yes.
Plus it is expensive. And it is expensive.
It is?
Expensive.
Yeah. Cost factor, I didn't even talk because, you know, we take it for granted that the patient can afford it. Yeah. Yes, Professor Handa.
You do check CT or MRI on day 3. Any experience of intraoperative MRI?
Oh, very, very good question. Unfortunately, I am one of the poor lot here who can't afford an intraoperative MRI. But if it is there, then maybe, yes, I can try that. But believe me, the quality of... So we also had a debate with Professor Kassam. So Professor Sethi may be watching now. I gave him a message. Maybe he's also watching. He also has an intraoperative MRI in Singapore General Hospital. So what happens is that the quality of the intraoperative images are not very good. If you look at it, it's not like the 3 Tesla images or something like that. So if you leave behind a very small residue during surgery, it is not very well picked up, even in pituitary or something like that. Maybe the advances in MRI will give you the answer. If you have an intraoperative MRI, well and good. But I have no personal experience on this. I'm sorry. But do you have one? Then it's the best situation for any skull-based tumor. It's the best situation. Yes. So any other questions before we go to Dr. Tyagi?
Any questions?
Yes. Oh, the Don is there. Yeah.
I had to wait and sit because you left me speechless. So I was getting my voice back before I could ask you something. You speak about 36 hours later in MRI, right? For the residue.
Not MRI, CT. CT with contrast.
CT MRI. CT for the residue.
With contrast.
Okay. CT with contrast.
Yes.
Now,
CT.
Yeah. You decide on the basis of that you're going to go back in again and remove that bit of residue?
Good question. Very good question. Very good question. So, his question was, just to make you understand that question, he says, if you find a residue, will you go back and operate? So the answer to that is 2 ways. One, there are residues which we leave behind on purpose. For example, the patient does not give a high-risk consent. He says, oh, the ICA, don't operate. Then what we do is we leave behind that residue. In that, we take the post-operative MRI, show him, and then send him to the gamma knife. But every surgeon cannot be God or cannot be perfect, so he will leave behind a residue somewhere. So this is why I insist that you take a post 36-hour CCT, and then within 10 days or 15 days before the patient gets discharged, we go again and operate.
Yeah, so that's my point. So let's say you do the CT and you decide there's a residue. Now, on what basis do you decide that this residue I'm going to go back inside and remove, or this residue I'm sending for a gamma knife?
Yeah, that is a very good question. Again, it depends on the location of the residue and the consent of the patient. So, and the competence of the surgeon. I underline that finally. So what I mean to say is, if you have left behind a residue in the infratemporal fossa, then there's nothing. You can just go inside, just take it. It's going to be a maybe 15 minutes or 20 minutes job. But if you have left behind in the cavernous sinus, in fact in the lateral compartment, so we had another argument between compartments of the cavernous sinus, which compartment will you go back? I would think about going into the lateral compartment because of the incidence of 6th nerve, 3rd nerve, 4th nerve palsies, and so I might leave it for a gamma knife. But if it's going to be in the anterior inferior compartment or the medial compartment, which is very rare, or the posterior compartment, I would still go ahead. If it is inadvertent, go ahead and operate. So it depends on the location, it depends on the risk, consent of the patient, and number 3, the competence of the surgeon. These are the factors.
Perfect. Thank you very much. I told you day before yesterday you're going to be here. That case would not have stopped you from coming. Thanks for coming, Daniel.
Thank you very much. Thank you. Yes, I think we can go on with, yeah. You want to show some case?
Yes.
Please.
I want to start my case. If you and sir approves, it may be a wonder in...
No, I'm not yet approved, please. Don't take me for granted. I've still not seen the case also. Maybe some AY group you have posted, I don't know, but I have not seen the case or I have not given any sort of approval. I am not an authority, first of all, to approve. So that's very clear.
I want to just start the PPT. It is a female of 19 years. I have operated 3 weeks back. I have sent all the scan report to all the stalwarts, to all the groups, AOI groups and all ENT groups. They all said it might be a GNA, and I have operated on that girl and sent all my tissue to histopathology. A senior histopathologist from NCR, you might know the name, she is Mithilesh Chandra. She is very senior in NCR, and she told me, Tyagi, it is 100% a juvenile nasopharyngeal angiofibroma, and I am sending some ISC markers to the US. But you can present the case in any CME. So here it is. This is the endoscopic picture. This is proptosis, bleeds on touch. These are the scans. Pointer.
You want to comment on this? It's going to be something like an examination then. I'm leaving it now. Okay, fine. Right.
These are the scans.
Now, can you go one scan back? Okay. Dr. Raji, you want to comment? No comments. Huh?
Anthony, what's your comment?
Any comment about Ramaran sign in this case?
Yeah, you want me to comment?
Yes.
Yeah, so we will see this scan very critically. I'm sorry if I'm, I don't know. I'm going to give you my opinion. First of all, you don't have a posterior cut here. So I can see only till the level of the inferior orbital fissure. There's no pterygoid plates. You have not taken the pterygoid wedge. For me, it's very important to see the pterygoid wedge. And number two is that you can see the spread of this tumor, whatever tumor it is, you can see the spread. You can see that this part of the orbit is involved here.
Yeah.
Okay? It's involving the orbit. Yes, JNAs can do this. It can push the orbit. It can, it very rarely erodes the lamina papyracea. If you look at that, it actually goes through the inferior orbital fissure into the orbit, and it doesn't go like this. So number one. Number two is that you can see that there is, I cannot see the sphenopalatine foramen and the pterygopalatine fossa, so I'm not able to comment. But here, if I see the axials, there's absolutely no involvement of the, see that's the sphenopalatine foramen here. So absolutely, so there's one entity called extra nasopharyngeal manifestations of JNA. If you look at the papers, they have sort of, extra nasopharyngeal manifestations. There are several articles on that. Even females have been reported. They're not typical JNAs. They are atypical manifestations of JNA. And if you're going to put your case in that, then I'm sorry, you might not be the first. So you might have n number of cases which have been already reported in literature. So you might still be a JNA, but then this is not a typical CT scan appearance of a JNA. This is my view. I'm sorry if I'm not the authority, but you can ask maybe Karao. You can ask Professor Karao. He is the authority. Or you can ask Professor Sethi. Yeah, you can carry on.
Next.
So, where is the MRI with contrast? So you can see here that this is again the maxillary sinus. It's going right from the maxillary sinus. You can see that medial wall is completely eroded going into the maxillary. This secretions here. It is very rare for a JNA to, without going from the posterior wall, going through the medial wall into the maxilla. I'm not very sure about that. So again, points for and against. So this is definitely a contrast enhancing mass. I can see that. And this is the central necrosis. You can see the central necrosis here. Dr. Anthony, you want to comment on this? See the central necrosis here. There's peripheral enhancement here. What do you think it could be?
It should be a rhabdomyo.
Yeah,
something like this.
That's the closest DVD.
Yeah, but immunohistochemistry will tell you what exactly is that.
Yeah, IHC will tell you. So what are the IHCs you have done? What are the markers you have done?
Androgen receptor.
No, but did you do the CD14, CD31 and all this stuff? Did you do the actin receptors?
I have done all the ISC markers.
Okay.
They are still awaited.
Okay.
All the ISC markers.
Okay. Then
all
I think we cannot
ISC
comment till the IHC markers come. Until then, we'll have to wait. So that's my comment. But anyway, a very interesting case.
And this is the external cavity ligation.
Again, I'm sorry, I disagree with you on ligation. Now I don't ligate. We
part.
only clamp the BECA, because if you ligate, what happens is that it gets its blood supply from the ICA territory. So that's something. Anyway. Nasopharynx? Yeah.
This is nasopharyngeal part.
Okay. This one? This is the JNA?
Pardon?
This is the JNA? In the nasopharynx? You mean this is the JNA? This doesn't look to me like a JNA at all.
Okay.
Yeah, basically it's a mass which is in the nasal cavity, nasopharynx, goes inside the maxilla, goes inside the ethmoids and into the orbit. It's a tumor which is in the ethmoid area, centric, spread in all directions. Looks like a, what's the duration?
And this is histopathological.
What is the duration?
Histopathological report.
No, histopathology, how many of you have got reports about JNA in the audience? Like, Dr. Handa, can you comment on this?
See, even if you are saying, showing a lot of vascular spaces akin to JNA, we have had diagnoses like angiosarcoma, where the spread of JNA is not there, but you may have had some bleeding and this sort of a spread. So, the radiology picture, the morphological picture doesn't match a JNA.
Okay.
And all the more it's a female.
And this is histopathological report.
Okay, it's a very good case. Thank you very much.
Thank you.
Yeah, thank you. So thank you very much. Thank you.
Thank you, Janaki Raman.
So we move on to our next session, that is congenital middle ear anomalies, a challenge for otologists. And I invite Dr. B.P. Tyagi to come and chair the session. Thank you, sir. Dr. Tyagi is the HOD at the ENT. Dr. Tyagi is the HOD at the ENT department of Columbia Asia Hospital and the director at the Hirsch ENT Hospital, Ghaziabad. His special interest areas are scarless endoscopic eardrum repair, head and neck oncologic surgery, maxillofacial trauma surgery, and OSS surgeries. Very recently, in September 2017, he had been invited at the Global Indian Summit at the House of Lords, London, UK, for his achievements and tremendous efforts in the field of ENT-related surgeries and towards providing free treatment and surgeries to poor patients. He holds a Limca Book of World Records for conducting 55 ear drug operations in an approximate time span of 17 hours on the World Health Day in year 2015. I hand over session to him.
The speaker is Sarafuddin PK. He is a senior consultant ENT and head neck surgeon from Accent ENT group of hospitals in Kerala. He passed MS ENT from Kottayam Medical College, MG University as the best outgoing postgraduate. His special interest is in oncology, neuro-otology and skull-base surgery. He has availed training under the guidance of great personalities like Stamberger, Jacob Magnan and other dignitaries. He is an empowered committee member of Kerala Government Deafness Prevention Program and M-Panel implant surgeon of Cochlear State. And he is an executive committee member of prestigious Association of Indian Society of Otology, and he has organized many national and international CMEs and workshops, and his center is NABH accredited.
Thank you, sir, for the introduction. At the outset, let me thank Dr. Sheema, Vaishali, Mukhtar, and the whole team from CIPLA for having me here this evening for this talk. After the rhinology sessions, maybe 3-4 sessions, especially after the rhinosinusitis and the antibiotic, and of course the Janagi's JNA session, we will move to the otology. Of course, I will start with a small, before going to the real session, I will start with a small trailer of a very famous movie. It's a very small trailer. Sorry. Sound.
Part of the ocean. There is no island there.
Yeah.
Baby, easy peasy. Let's go.
Most of you might have seen this film.
That's my security system.
I'd rather take the Titanic.
Here's the deal. A few nights ago, a radio signal got sent out from these coordinates. It could be the mysterious island that Jules Verne wrote about.
You think you're going to travel halfway around the world and meet up with some lunatic who's messing around on a ham radio?
It's not some lunatic. It's my grandfather. He's been looking for a mysterious island over half of his life.
So this is a small trailer from the famous film by Dwayne Johnson, The Journey to the Mysterious Island. So I thought I will just show this just because when we see a patient with a conductive hearing loss with an intact eardrum, especially when we explore or when we think of congenital middle ear issues, we don't know what will be there inside. So like the mysterious island in this picture, they see big animals like elephants as very small creatures, and very small creatures like very small insects and all, very gigantic animals. So as like that, when we open a middle ear with intact eardrum, especially congenital ears, it's often very surprising, and very sometimes we will see we may have to even abandon the surgery. So these children are not only challenged, or these type of patients are not only challenged to the surgeons, but often these are challenged to the anesthetist also. But most of the surgeries we do under general anesthesia because of their peculiar issues. They are challenged to the anesthetist also. When we go to the classification, there are different classifications, major and minor, and different classifications. The most accepted classification is the Chinison's and Cremer's classification, where the majority of the cases are the isolated stapes issues. It may be the stapes fixity alone, or stapes fixity associated with other anomalies, or mobile stapes with other mobile stapes with other ossicular anomalies, or even very severe anomalies like the facial nerve anomalies, or stapedial artery, persistent stapedial artery, or extra ossicular anomalies. So the diagnosis here is often very difficult. The patients may go repeated ventilation tube insertions or repeated suspicion about SOM and all. Then sometimes you may see some findings like the abnormal findings in the pinna. You can see the different sizes in the pinna, some fusion in the helix and the hand helix sometimes, and the HRCT. HRCT is very useful in this diagnosis when you get a conductive hearing loss. When you suspect some congenital anomalies, HRCT, especially the very thin slices, 0.6 millimeter CTs, especially with multiplanar reconstruction, they are very useful. You can, if you reconstruct them very well with a good radiologist help, you can see the ossicles, you can delineate the ossicles, you can see the anomalies of the middle ear structures very well. This is one of our patients. You can see the stapes arch is not very well seen. And when we get a patient like this, how to approach is also very challenging. So whether to go for surgery, whether to go for a hearing aid, whether to go for some bone conduction devices like BAHA or cochlear implant or something like that. So we had all these type of congenital anomalies in our series. So this is the class 1 anomaly where you will get a stapes fixity. All other ossicles will be normal. Here you can see the stapes fixity may be either at the annular ligament or in the foot plate of the stapes, or the stapes fixity may be a bony bar fixing the stapes from the promontory or the facial canal. Here you can see there is a GUR in the posterior crest of the stapes. There is no stapedial tendon, there is no pyramid. So in this type of patient, it's always better to do a reverse stapedotomy. You make a control hole and you do the reverse stapedotomy like this. This is the simplest anomaly, that is a congenital stapes fixity. All other ossicles are normal. And you will get a relatively good result in this type of patients. You will get a fairly good AB airborne closure. This patient, you can see the mother and the daughter. Here the patient was the daughter, presented with conductive hearing loss. Both of them had congenital nystagmus also. If you get this type of patients, you can suspect some congenital middle ear anomaly. You can see this type of patients have congenital nystagmus and other anomalies. Luckily, the mother had no hearing loss. So when we opened the ear of this girl, here you can see the ingus long pros was too short. There was no suprastructure, but the stapes was fixed. But the ingus was, you see, it was too short, and the malleoinguinal mobility was normal. So here a malleostepedotomy was done. Because the ingus was too short, it was not possible to do ingus stepedotomy. So a malleostepedotomy was done. That is a class 2 anomaly, where the stapes is fixed, but it is associated with other ossicular anomalies. Here you can see is another anomaly. You can see the ingus. There is only a fibrous band connecting the ingus with the posterior wall. There is no pyramid and all. There is no suprastructure. Here also, a ingus stepedotomy was possible. Here also the foot plate is fixed with a short ingus and no suprastructure. This is another patient. Here you can see a bony bar from the posterior wall of the middle ear into the suprastructure. And here you know there is no crest connecting into the foot plate. The head is there, a small crura is there. But there is no connection with the foot plate. You can see the suprastructure. It's only part of the suprastructure is there developed. See, there is no full crura. There was no connection with the foot plate. Here again you can do the ingus stepedotomy. This small girl, 9-year-old girl, you can see, She also came with a conductive hearing loss, and you can see the timinogram was AD type. And when you open the middle ear, see the ingus is not very well formed, and the suprastructure again not well formed. It is not connected with the foot plate. But here you see the foot plate is mobile. You see the foot plate is mobile. In the other two classes, the other two divisions, the foot plate was mobile. But in the third class, the foot plate is fixed, mobile. So this is a little bit challenging. Mobile foot plate with ossicular anomalies. Here we remove the suprastructure and we line the foot, the foot plate area with a fascia graft, and we would a total ossicular replacement or prosthesis supported with a congal cartilage. So this is again, it's a class 3 anomaly. There is no suprastructure here. There is a malleus is there. There is a very short ingus with a fibrous band. Here the foot plate is mobile. That is the important thing. So there are different techniques you can use. Either you can use a total prosthesis, total ossicular replacement prosthesis, or you can make a fenestra on a mobile foot plate. Here we are making a fenestra on a mobile foot plate very carefully. And you can put your prosthesis. So this is another type of class 3 anomaly. Here you can see the malleus is there, but instead of the stape, there is no stapes suprastructure. There is no ingus also, but there is only the mobile foot plate, malleus and a mobile foot plate. Here also, since the ingus was not there, we performed a malleus stepidotomy because the ingus was not there to make a ingus stepidotomy. The malleus is skeletonized and relocated a little bit posteriorly. That is a malleus relocation. Then we made a malleus stepidotomy on a mobile foot plate. This is the class 3 anomaly. You can see the malleus, malleus stepidotomy. Processes from the malleus into the foot plate. This is audiogram of the patient. You can see the airborne gap closure, but still there is a residual airborne gap of about 10 to 12 dB still there. This is one of the very interesting anomaly. Here you can see the malleus and ingus is a bony mass. There is no malleus as such, there is no ingus as such. Instead, there is a bony mass and there is a fibrous connection into the stapes. It's an abnormal stapes. You can see a long stapedius tendon with an abnormal suprastructure with a small fibrous connection with a conductive hearing loss. You can see a mobile stapes. See, the stapes is mobile. In these class 3 anomalies, the mobiles will be mobile. The stapes will be mobile. Here a cartilage strut was kept between this bony mass and the stapes suprastructure, the mobile suprastructure. If the patient was not that much happy after the surgery, so we are planning to revise the surgery because the patient at that time we had no total process or partial processes with us, so we are planning a revision surgery for him. So this is the more severe type of anomaly, that is a class 4 anomaly. Here you can see this patient, when we open the middle ear, The ingus, you can see very rudimentary ingus is there, very rudimentary malleus is there, and you can see the facial on the promontory. The oval window is just a niche is there. There is no typical oval window is there. This type of anomaly is very tricky and sometimes very dangerous to do the surgery also. Here you can see the malleus. It's not the typical lateral process of malleus or the handle of malleus. Here we made a fenestra into the promontory. You can see the fenestra is being made onto the promontory just close to the facial without injuring the facial, and a promontory fistula is made and the process is crimped into the malleus and into the promontory. The patient had improvement fortunately, and the patient was happy. Still the little bit nearly 15 dB airborne gap is still remaining, but the patient was happy. So this is also classified under the class 4 anomaly. It's very rare situation to have a persistent stapedial artery in the middle ear. This is extra-ossicular congenital anomaly in the middle ear. Persistent stapedial artery is very rare. If at all it is there, may be very difficult to do a stapes surgery in this type of patients. So this usually it's a branch of the usually the branch of the internal carotid system. So this patient, you can see the stapedial artery was almost filling the foot plate area, and fortunately you can see we could make a small fenestra close to the artery, and we made the introduction of we could introduce the processes into the fenestra, and the patient got the hearing. So this is the extra-ossicular middle ear anomalies, like you can get a persistent stapedial artery, or you can get a congenital perilymph fistula, or you can get a aberrant carotid artery, or you can get a very highly placed jugular bulb into the middle ear. These are all the extra-ossicular anomalies of the middle ear region. So the class 4 anomalies, most of the time you may have to abandon the surgery, and sometimes you may cause sensorineural hearing loss. So it is very challenging. So you may have to discuss with the patient and the relatives whether to go ahead with the surgery or to give the option of the hearing aid. So I thought I will share this type of rare anomalies because this is a real challenge to the otologist. So, and to also, it's very controversial what age to do the surgery, when to do the surgery, whether to go for some hearing devices in the early childhood and all, and what to do in the unilateral cases, what to do in the bilateral cases. It takes long time to discuss all these cases. So I thought when we open a middle ear with a conductive hearing loss intact eardrum, we should be prepared for all these type of anomalies, and we should be prepared for all types of processes also. That is the take-home message from this presentation, and thank you for your patient listening. Thank you.
So good evening. I have a few questions, sir, for you.
Yes, sir.
Are you doing HRCT of these patients preoperatively routinely?
I can't hear you, sir.
Scanning, HRCT temporal bones, are you doing routinely?
Routinely I have started doing now.
Now?
Yeah. The HRCT I showed in the initial things are all the patient's HRCT. So the last class 4 anomaly I had not taken the HRCT. But most of maybe the 50% of the patients I have presented I have taken. So now for each patient I am taking the HRCT.
Second question is, you have shown a lot of congenital fixation of stapes, those you have done. My question is, have you come across any gusher when you are doing stapes surgery for this congenital people?
I can't hear you, sir.
You can't hear. Are you getting any gusher?
Any gusher?
Gushers.
During the stapes surgery.
During stapes surgery or whatever congenital anomalies you are operating?
I had some ooze, sir, not the gusher.
Not gusher, not a major gusher.
Not the gusher, real gusher. The real gusher usually you will get when there is a wild IAM or wild cochlear aqueduct. So when you get as you initially told, in the initial days when we tell the patient for HRCT, many of the patients, they won't agree to take the HRCT. But now I insist, because when we open a congenital middle ear, you have to take it. It's mandatory, because you can avoid surprises. Especially even it is a persistent septal artery, if you take an HRCT, you can see if the foramen ovale is not there. If the foramen spinosum is not there, you can anticipate that there is a chance for absence of middle meningeal artery, and there is a chance for PSA, persistent septal artery. And also you can see the facial nerve, so HRCT is a must. And also you can anticipate gusher if you take HRCT. So now for the last nearly 2-3 years, I have started HRCT in all patients.
Couple of cases which you had shown, you are doing a hole in the foot plate, which is a mobile foot plate.
Yeah.
Are you using any laser, or you are using routine perforators?
With Skeeter and also with the perforator.
Skeeter and perforator.
And perforator. But I prefer now with the perforator, not with the Skeeter.
Laser you don't try?
No. On a mobile foot plate, now I prefer with the perforator.
Okay. It has been stated, and there are a lot of papers about these different congenital anomalies, those who are operated. There is a definitely late sensory neural loss, or immediate even a sensory neural loss in most of the cases. What is your experience?
I didn't hear you, sir. It's very difficult to hear from you.
You can't hear?
No.
Hello? Now you can hear me?
Yeah, now better.
Yeah. There are a lot of papers, and it has been always told that congenital anomalies, when they are operated, there is a chance of sensory neural hearing loss. The late sensory neural hearing loss is almost known in most of the cases. What is your experience?
Not most of the cases, sir, because the class 1 and class 2 anomalies, there the results are not much difference. Initial days, all the initial papers say that it is better to wait for the surgery till the 10, at least 9 to 10 years. But the Professor Lippi et al., he has very maximum number of, one of the otologists with the maximum number of Stapy series. They are all advising you can do the surgery in the very early age without much injury to the inner ear, or with much injury to the sensory neural hearing loss. So the chance for sensory neural hearing loss is more in the class 4 anomaly. In the class 1 and class 2 anomaly, there is not much chance for SNHL. If you are very careful, if you are very experienced, and these are all mainly depend on the experience of the surgeon and the technique you use and the processes you use, many factors, because Stapes is rather something like a technical surgery.
Yeah, I fully agree with you.
So, and the class 4 anomalies, there is a very high chance for sensory neural hearing loss, so you have to be very careful.
Thank you, sir.
Thank you.
Thank you, sir. One question from you. How would we, as ENT specialists, approach a case of conductive hearing loss with an AD type of curve in tympanogram?
I can't hear.
All these patients should be subjected to a routine high-resolution CT scans?
Can you repeat, sir? I can't hear.
Conductive hearing loss with an AD type of tympanogram.
Conductive hearing
How
loss?
should we approach these cases?
We are getting late. We can discuss later on the dinner.
I can't hear you, sir. You have a mic? You want to discuss later? If you have a mic? No, I couldn't hear his question. Can you please tell? I couldn't hear your question. I will come here.
Hello?
Yeah.
Yes, sir. I wanted to ask you that in a patient who's having a conductive hearing loss with an AD type of curve in tympanogram, how we should approach further evaluation of these?
AD type of
Yeah. Should we routinely go in for this high-resolution CT scan suspecting some kind of a congenital anomaly, or something else is there?
if the patient has a conductive hearing loss with an intact eardrum, if the airborne gap is quite big and if the patient is symptomatic, whatever tympanogram you get, you have to explore. The best diagnostic test is exploratory tympanotomy, even if you can't believe HRCT. But you have to take an HRCT, because I have got many AD type of curve without discontinuity, many AS type of curve with discontinuity. So even if the use of some of the videos with the crura without any connection with the foot plate, so they were touching the facial canal and the promontory. So that may be, I don't know, maybe seen as an AS type of curve or A type of curve without much compliance. So the best diagnostic, definitive diagnosis is exploratory tympanotomy. All this will help you to diagnose, to confirm your diagnosis, and also the main thing is that to avoid your surprises, like abnormal facial, highly jugular bulb, highly placed jugular bulb of the posterior septal artery, or a perilymph gusher, as sir was discussing. Wide IAM, wide cochlear aqueduct, all this you can anticipate. That is the main advantage of HRCT. Even if you don't get any idea from the middle ear, you will get any other, you can avoid surprises. You will get a lot of points like this. So the best thing is that even if you get an AD curve with a conductive hearing loss, you have to do an HRCT and you have to proceed with an exploratory tympanotomy. That's all. That is the diagnostic procedure, exploratory tympanotomy. You have to open and see.
Thank you, sir. So we move on to our next session, that is pediatric airways, and I invite Dr. Alok Agarwal and Dr. Ramanuj Sinha to come and chair the session. Dr. Alok Agarwal is a renowned otorhinolaryngologist having more than 28 years of experience. He is a senior consultant at ENT Department of Sir Gangaram Hospital, New Delhi. He was the president of Delhi AOI in year 2017-18. He is also an active member of Indian Society of Otology Rhinology Society of India and Indian Association of Surgeons of Sleep Apnea. His major focus areas include pediatric otorhinolaryngology, laser and coblation surgeries of ENT, sleep apnea surgery, and cochlear implantation surgery. Dr. Ramanuj Sinha is the head of Department of ENT, Medical College, Kolkata. He is fellow Indian Academy of Otorhinolaryngology, Head and Neck Surgery. He is ex-president AOI West Bengal. He is the examiner of GNB and he has 59 publications to his credit. I hand over session to both the chairpersons.
So for the next session on pediatric airways, I invite Dr. Divya Pravat. Dr. Divya Pravat is an experienced ENT surgeon with the track record of serving thousands of satisfied patients from all over the globe. He is a sought-after speaker for national and international conferences. Dr. Pravat is also an associate author and has authored many successful books on ENT. His books are considered the best books in ENT. He is an editor of IAP, Textbook of Pediatrics, Indian Practitioner General, Text of Adolescent Medicine. He is attached with the India's premier hospital, Bhatia and Wadia Hospital. He also manages a private hospital at Dadar, Mumbai. He has widely traveled across the world and regularly conducts ENT surgery for Indian and international patients. He has published 36 research articles and presented many papers in national conferences. Dr. Divya Pravat, please.
Before Divya, many thanks, Divya. I know you for a long time and I have gone through your books and I think it is one of the best books for the PGs. Thank you. Go ahead.
Thank you for a very generous introduction. Respected seniors, colleagues, friends, especially Dr. Seema Sheikh. I'll take you through a small journey of airway which we are experiencing at the various hospitals that I've been working. And over the last 25 years, we have done over 7,000 endoscopies in these children. And with this small experience and with other hospitals, I would just go through it. Now, when you see a child, a child is much different from an adult. And these are the things that will differ a child from an adult. A large head. They are basically obligatory nasal breathers. the moment the nose is closed, the child gets breathless. In fact, we've lost children who have absent noses. The tongue is large. If you consider the oral cavity, the basic space occupied by the tongue is much more in a child than an adult. The subglottis is narrow, the epiglottis is floppy, the mucosa covering it is very loose, undergoes edema very fast. The anterior larynx makes it difficult for intubation. The trachea is smaller, the lung capacity is much less. So in short, this is all that makes the difference in the airway. And what you see, that within a minute, the saturations fall down like anything. Before the child saturation falls, the surgeon, the ENT surgeon's heart stops. In fact, we have incidences where the saturation on the table comes down to 0. And then again it goes back to 100 within 60 seconds. It is just like you're driving a Ferrari. Within 60 seconds, 0 to 100, and the child becomes fine. The basic problem mainly comes at the level of the subglottis or the cricoid, which creates all the problems. And as you know, the normal, natural, the smaller area of the trachea, just with 1 millimeter edema, only 1 millimeter edema can reduce the cross section to about 75%, which is so drastic, and that explains the sudden fall and the sudden rise in saturation of these children. So this is typically to show you the child who had absent nostrils. We could not save the child was lost in few minutes. Those who have one nostril open are comfortable. Even if it is a corneal atresia, if it is bilateral, it becomes a surgical emergency. So you all are aware of this. We have Dr. Pereira, who is an expert on this. You do opening of corneal atresias. So the moment we get a child with a respiratory problem, the positioning will help you a lot. The positioning meaning where we keep the folded towel or the pillow. Normally, if you have kept it below the head, that will reduce the airway to nearly 50%. So rightly keeping a small towel or a folded cloth below the shoulder would definitely help a lot. Now, how to assess that this child has what condition? You should know the time when all this has occurred. So if it is following delivery, you would think of a stenosis or a web. If it is with feeding, you think of a tracheoesophageal fistula. Up to 3 months, laryngomalacia, or it may be a hemangioma gradually increasing in size. Following intubation, very common, iatrogenic, with colds, laryngotracheobronchitis. So whenever there is a period at which the respiratory problems start, your diagnosis would be zeroed down to these things. So how do we assess the child? First, always see the child from a distance. Don't go and examine the child as soon as you get the patient in, because they don't like strangers. Once they start crying, you lose all your findings, you lose very important, crucial findings, which will be more important than any of the investigations. Then the breath sounds, the abnormal airways, and the restricted. Unilateral airways, you all are all very aware of. Then we come to smaller cases. Child having a breathing difficulty, there was dysphagia also. Just putting in the tongue depressor, saw a big, huge bulge, and naturally with a diode laser, they removed it. After doing a scan, knowing the normal thyroid is well in place, and this normal thyroid would be enough. You must have seen this picture where you know that snoring affects adults. But the same snoring is quite damaging to children, and the commonest thing that you see, of course, is adenoids. And we see a lot of adenoid children now who come in LD clinics, and they are referred from LD clinics of late development. They have serous otitis media, speech development, and all that is adenoids. I would not like to, of course, talk much on it. And as we go down, you can put in the laryngoscope, you would see hemangioma, again a common condition. Unfortunately, most of them, come to us as laryngomalacia. Earlier, since the larynx was not seen, these children were labeled as laryngomalacia. When they did not respond, we come to know that there are various other conditions that are there in the larynx or in the airway. So hemangiomas, hygromas, in fact, for hemangiomas, what we do is we keep them on propranolol. The pediatricians manage them, and that is the way how regularly, the hemangiomas go down. The other thing that again comes as laryngomalacia is a valvular cyst. Valvular cyst, a common condition. If it does not clear with steroids, we use the diode laser, and the diode laser opens up the cyst. A simple IND sort of a procedure, followed by marsupialization, which would definitely treat the respiratory problems considerably. I'll just go faster because we are running short of time. Then stridor. The stridor, you have to note that when the stridor is occurring, is it inspiratory, expiratory or biphasic, and depending on them are various common conditions. So typically in infants, you may see with cardiac conditions especially vocal cord palsies, and these vocal palsies most of the time recover on their own. You just have to avoid respiratory tract infection because they all worsen with URTIs. This again, child was referred as a laryngomalacia, found to have a vocal, glottic web, slit open and treated. The commonest condition in stridor is laryngomalacia. Now what I would like to tell you here, that over at least 25 years, we have not operated a single patient of laryngomalacia. Most of them are either in school, some of them in college. I know somebody who's working also. So laryngomalacia, better not touched. With time, it clears on its own. The diagnosis is that the normal size tube goes in, and as far as possible, just see that respiratory tract infection is under control. So that is when they miss out. Laryngeal cleft. Now, one very important condition is any child having undergone any surgery. The commonest problem at the subglottic level is the endotracheal tube. A fitting endotracheal tube is wrong for a child. Always put a tube which is one size smaller. A tube which is enough for airway is the right tube. So fitting tube never should be put into a child. And this is just last week's child where endotracheal intubation, you can see how the edema occurs at the arytenoid, or even the posterior pharyngeal wall is torn, would definitely require a tracheostomy to be salvaged. So these are all iatrogenic conditions which are all salvageable, all avoidable. These are new tubes which are used which would reduce stenosis. So that is what we find on the scans, and typically complications occur with tubes either being of fitting size, or if the child is not well sedated, and if the tubes are there for a long place. So of course I would not go in for these are longer videos. What we do is use this wrongly written as CO2, it's a diode laser where Mercedes-Benz incision, tri-radiate incisions are taken on the stenotic part, trying to damage as less as possible of the mucosa, otherwise again it would re-stenose. Then if it is still of a greater degree, or grade 2 or grade 3, costal cartilage grafts are taken and they are harvested with a cricoid split. These are subglottic granulomas which form where tubes are there for a longer period, again removed by diode laser. We'll go ahead. Now if stridor is associated with dysphagia, it is important that we do a MRI, we do a barium, and these would generally give you a picture of persistent vascular conditions which are obviously not treated by ENT. The thoracic surgeons take over and they really treat these children. So whenever there is a child of stridor, it is important to see the pulse rate. A rising pulse rate is the most reliable sign that this child is worsening. And just to show you that what we did at the nursing home level with one of my colleagues, ENT colleagues, it's thankful to him, that we had a child where he called us to his clinic, and the child had stridor. Typically you can see subcostal retraction, intercostal, and on putting the laryngoscope, endoscope, the whole larynx was closed. They came so late, so naturally immediately a tracheostomy was done. from the tracheostomy, you can see we saw the bronchus, I mean it was normal. And then retrograde, the endoscope was put in to see the subglottis. The subglottis you can see had totally closed down. I mean people wait so late, and at that same sitting we put in the ML scope, and with the CO2 he cleared it off. So these conditions, meaning these things even are done at private clinics, and it's quite rewarding when you find the airway clearing up, and in 4 or 5 days the tracheostomy is removed, and I can just show you the vocal cords are normal, the voice was absolutely normal. So sometimes they come so late and you don't know what is there inside, that doing an endoscopy becomes like an ear exploration, what you saw just now. So now we'll come to bronchoscopy. Bronchoscopy is done for an umpteen number of conditions. Then bronchoscopies are done not because as ENT, our focus of bronchoscopy is only foreign body. But there are so many medical conditions where bronchoscopy is done that who is to do a bronchoscopy was also a big question. And we run these bronchoscopy workshops regularly in Bombay. And in the workshops, hardly you ever find any ENT person coming. Unfortunately, most of them are either pediatricians, chest physicians, they are pediatric surgeons, and very few ENT people do come. But I feel very happy to say that some of our residents who are there outside, even in Nanded, Sholapur and etc., they've rung me up 2 months ago and said that in private I've done 1,000 bronchoscopies now. So it's really heartening that so much of work is there. If the ENT starts doing it, bronchoscopies will start coming in even private clinics, etc. Now this is a case where persistent cough. This child had 9-year-old, TO fistula is detected, and again this was at Vadia where we did a bronchoscopy. Through the bronchoscopy we found out the fistula site. You can see the bubbles. Because there's an RT inside, just flush in air and you find bubbles coming. And through the fistula site, a ureteric catheter size 4 is inserted. Tissue glue, that is Rayleigh we put in and close the fistula. So, lot of procedures which are maybe supra-major are done in time of 10 minutes or 15 minutes, and you can close it down, basically. We'll go to this. Similarly, as I told you, patient coming for routine collection of secretions, you would think, we thought it will be a foreign body, just remove the secretions and immediately you find the lung opening up. So, clearing of mucous secretions, doing alveolar lavages forms majority of the bronchoscopies that we do. This was a paper in American Academy where one of our residents presented that 18% of the bronchoscopies that we have done were for foreign bodies. Rest of them were for non-foreign body conditions where pneumonias, untreated LRTIs, fungal pneumonitis and all were treated. But since we are interested more in foreign bodies, I would just stick to it. We find everything under the sun, from wood, rice, cement, everything down. Now this is a child who just recently came with stridor, not knowing what the condition is, and putting in the scope, we found a piece of cement. Now these children who have foreign bodies in the larynx or in the trachea have normal air entry, both sides, give steroids, it clears up, the child is comfortable, they go home. So you find all sorts of things. Again, 4-year-old male, cough, treated by pediatricians in the IPCU. When the whole lung collapsed, just for secretions they send it to us. This was I think at Bhatia, where we did the bronchoscopy and immediately found the lung opening up. And what was there inside? These are pieces of chicken. The child was eating a burger. So there was a history of eating burger and you found chicken inside. And when these chicken fries came out, the hospital authorities, this gives you a lot of attention by the hospital, media. They like these things. You do hundreds and hundreds of tympanoplasties. Nobody tells us you've done such a nice ossiculoplasty. You do so much of FES. But nobody remembers that, what a fantastic, polyp I've removed. But when you remove a foreign body, immediately the whole hospital talks about it. The media jumps at this and you get fame, publicity, whatever, etc. because of this. This was again last month. The child was on a ventilator in private for 3 days, in another hospital in Sion for 3 days, and you can see such a big earring inside. So it was in the trachea, and with the foreign body, the endotracheal tube was in place. So you can see this was the endotracheal tube. When they remove the endotracheal tube, you can see the picture of the mucosa over the foreign body. So such a big foreign body, and that endotracheal tube put in without diagnosing such a big foreign body. So you get all types of patients where foreign bodies are, such big foreign bodies can be missed. It's very, alarming. You may also get foreign bodies which may just be straight into the trachea, like the cement piece you saw. You have a coin which is stuck. We've got it 2 or 3 times, I think, in the Cholet position. Air is going inside both the sides. The coin is straight. The air entry is normal. The patient is fine, and So what this teaches us, it is important to remove 2 X-rays. So always remove 2 X-rays whenever there is a suspicion of a foreign body. It was long ago, before I joined KEM, our seniors had told us that a businessman came to the casualty and he told the casualty officer, "Mere bete ne 5 paisa khaya hai." The casualty fellow, urgent X-ray, and then he saw a foreign body, called the houseman called the registrar, that the child has eaten a 5 paisa. He said, "This doesn't look like 5 paisa, this looks like 3 paise." He said, "Anyway, whatever 5 or 3, I have to remove it." He called the anesthetist, did the scopy, removed the foreign body. There was a 3 paise coin, and with that there was a 2 paise coin. So a second foreign body is also a common thing. Don't ever think that if one foreign body has come out, the second may not be there. Always do a check scopy, always do a second X-ray, and that is mandatory. Again over here, just recently, we had a foreign body in the bronchus. One was removed, check scopy, and again one more inside. So radiology, not detecting a foreign body is very common. So we cannot really depend on radiology on this. Again, just recently, there was a pin which pierced the bronchus and had gone in, so it had to be removed in bending it. Post bronchoscopy, of course, a child where the child is comfortable, immediately an hour after bronchoscopy. Now the problem with foreign body in the bronchus in children is that there is no history. The child is smarter than the parents, the child is smarter than the caretakers. So history you would never get. Secondly, the signs keep on changing. The signs keep on changing. Initially, these children are treated as bronchiolitis. After a week, they are treated as pneumonia. After a month, they are treated as tuberculosis. And then they are treated as asthma. So they can mimic diseases very well, and they can be treated on that. And to compound the problem, the doctors also keep on changing. So this is the problem with foreign bodies that occur in the bronchus. This is typically how a foreign body, I would not go to the videos, I think it's all the similar videos will be there. So when you see a normal X-ray, also there could be a foreign body inside. It may also show emphysema, which may be either obstructive or compensatory. There may be collapse, and there also will be a mediastinal shift if one bronchus is totally blocked. So these are the different types of findings that you may get with an X-ray. So all types of findings can be seen. Now typically patients taken for lavage, and we find chiku seed inside. Neither they had suspected nor we suspected. Finding clove or long inside, where patients are taken for just an alveolar lavage. Now specifically some foreign bodies, I'll just show you that this child came with cough. He was diagnosed with pneumonia. Then he was treated by the chest physician in, I think, Malad for AKT. Counts kept on rising, cough was persisting. On the CT, then we saw a block after 6 months, and then we removed such foreign bodies. So such foreign bodies also, they don't give history. Big children also don't give history. Missed foreign bodies, given AKT, not responding to AKT for 6 months. They are labeled as multi-drug resistant tuberculosis. They are treated as MDR tuberculosis to that level, and what we find inside is foreign body. So the changes reverse after a bronchoscopy, and MDR tuberculosis level, I mean, imagine giving MDR for 1 year and still the foreign body is sitting in place. This again last month, one of our senior ENTs, I mean, hats off to him, he had taken this child for a TAR, tonsil adenoid. And on table, the anesthetist, when they auscultated, he said ki air entry barobar nahi hai. It said we asked for an X-ray chest and the case was postponed. And after the case was postponed, on the X-ray, they saw a foreign body inside. So at Vadia, we just did the bronchoscopy, removed this foreign body, and next week we did the tonsil. So I mean, no history, such big boys come with foreign bodies inside and detected on table accidentally. So typically the belt pin is removed. In your clinic, whenever you get a child with a foreign body or suspected foreign body, it is avoidable to do Heimlich's maneuver, avoidable to do heroic maneuvers, because you may not be able to intubate, may not be able to do a tracheostomy in an emergency, unless the child stops breathing, unless the child, because when they come to you, they will tell you, Doctor Sahab, aap to Bhagwan hai, you are the God. But the moment the foreign body from a right bronchus comes in and gets stuck in the subglottis, or a foreign body in the esophagus gets up and chokes the laryngeal inlet, you will lose the child. Nothing will happen if the foreign body is down inside, and the question of God will change if things happen, because this has happened, and that's why I just wanted to bring this out over here. So all types of things you find inside. Another child, just to emphasize another point, is was diagnosed as a retropharyngeal abscess, had 4 admissions with pediatrician, pediatric surgeons, and with 1 ENT, treated with antibiotics, responded, went home. Twice CT scan done, twice MRI done. With 4 scans, this had not cleared, and then we thought we just explore this child, and on putting in a scope, found granulation, and that granulation showed a pawn inside, a chest pawn. So what I want to say is, I spoke to the radiologist, CT scan done at different places, MRI done at different places, you can still find a foreign body inside. So what is required is your clinical acumen. What is required, you take a judgment on your own. It is easier to put in a scope and see, rather than giving GA and doing MRI for a patient. So 4 times scanned and still you find foreign bodies inside. Now as we say, age is a criteria. We have children who are 2, 3, 4 months also who come with foreign body. So you can find this child who is a 2-month-old child, has this button inside. So other siblings put it in while playing. So don't consider age as a criteria for foreign body going inside. Even adults don't give history. Since most of us sitting here see more of adult patients, I think, than children, so I thought I'll just give you an example of this, that when you see an adult also, you have to think of a foreign body. This was a 78-year-old female who had coughed 2 days, not responding. Fortunately, her nephew, I mean, this is a professor of ENT, it is his Mausi. So since he was an ENT, he said, okay, that could be a foreign body, do a scan. And he did a scan and found a blockage, a suspected foreign body inside. And immediately that night itself, I mean, we took this patient and I did the scopy and found a tablet inside. So people who are even 78 or at different ages do not give history of a foreign body inside. Typically 75-year-old male eating, you find in the bronchus, the teeth going inside into the bronchus. This is recently I saw an elderly gentleman again with throat pain. 1 week he was treated with antibiotics. He thought, GP thought he had suspected malignancy. Did a CT scan and you can find a tablet inside. And that tablet is what? He had 8-10 tablets. Physicians usually write hypertensive, diabetic, they have number of tablets going on. So what happens? The number of tablets they take, they forget that they've taken the tablet along with the metallic foil. So therefore, whenever you have even elderly patients, you have to think of a foreign body. Unlike like children, adults do not give history of foreign body, and elderly patient would never give history of a foreign body also. And all conditions which you see are so satisfying that you get immediate results and the patients are very grateful to you. Now I want to tell you that however rigid a bronchoscope that you use, it is atraumatic. It's very difficult to tear the trachea. With two hands you do a bronchoscopy, the trachea is not going to tear. A bronchoscopy, by a rigid bronchoscope, it is wrong that in the mind one feels that one may cause trauma as compared to a flexible. And even with a flexible, removal of foreign bodies becomes very difficult. In fact, we get a lot of patients from even chest physicians and all that it is a foreign body and we would like a rigid bronchoscopy to be done. So this is a training that we do on the goats for bronchoscopy in Bombay. And to end with, again this is a 38-year-old male, I think from Malabar Hill, where he had throat pain. He was on azithromycin, did not clear. Then he was advised an X-ray. X-ray showed that it is a ring, so they did a scan. The scan also confirmed that there is a ring inside. That's why his throat pain for this 38-year-old male. But when we did a scopy, this is what we found. So things like this also do not give history. You have patients of all age groups. You have to think of a foreign body. And with this I end my talk and enjoy your beer. Thank you.
Thank you, Dr. Dibba. You have touched the congenital conditions, foreign body. You have a number of foreign bodies. And one thing you have pointed, that is prolonged ventilation. Prolonged ventilation is one of the most important cause nowadays, prolonged ventilation in children. I think there is some audiological prolonged ventilation. Prolonged ventilation, you have mentioned it. Thank you. Thank you.
Yeah. Exactly.
Thank you for the beautiful presentation.
Yeah. Thank you. Thank you very much, sir.
Any questions from the audience?
Sir,
Any
questions? With your permission. Dr. Divya, laryngomalacia, 2 to 5 years, things resolve. What do you do till then? What do you do for the child till then?
For laryngomalacia, most important is to prevent URTI. There should not be respiratory tract infection. Moment you prevent respiratory tract infection, laryngomalacia will not cause a problem. And as you said, during the period, you have to always advise that as far as possible, child has to sleep on the side, good nutrition, increase the, immune system.
But
We have not operated any laryngomalacia. We must have seen at least more than 1,000. And all of them are fine.
Neonates who need ventilatory support, what about them?
Sorry, I can't.
Neonates who need ventilatory support, neonates diagnosed with laryngomalacia, who would probably need ventilatory support for a while. So how long and then what next? This is something that we face. We get a call from an NICU, suspected laryngomalacia. The child is on the prone side, has a problem, supine side has a problem, lateral side doesn't have a problem. They put him on a BiPAP, child is fine. How long? What is the next advice that I give them?
In some of them, we have done where basically for the tongue, they put a tongue stitch for a period, or you can do a tracheostomy, worst come to worst. But no surgery was done per se on the larynx. No surgery.
But you advise them to be on ventilatory support for a long time? Ventilatory
Not
support?
at all. You just give them steroids, their edema clears up and they can go home. We don't do any surgery for laryngomalacia.
If you're too busy doing bronchoscopies, where will you have time for laryngomalacia surgery?
So I didn't have.
I like to differ a bit on the surgery of the laryngomalacia. We in our hospital are dealing with very many patients of neonatal age group, and here we do the surgery with cutting the arioepiglottic folds and fixing the tongue with the epiglottis with the tongue by the use of the little bit of laser or bipolar cauterization. And it gives wonderful results. Within 24 hours, patient is out of the ICU and can be sent back to the home. So we are doing it on regular basis as far as the laryngomalacia is concerned.
Sure.
Thank you.
Thank you.
So we are coming to the end of the sessions, and the last session of the day is endoscopic management of adhesive chronic otitis media and cholesteatoma. And I invite Dr. Ramesh Rohiwal to come and chair the session. Dr. Ramesh Rohiwal is a consultant ENT surgeon and otologist, and he is practicing since Jan 1985 at Aurangabad. He has done his temporal bone course under the guidance of Professor Hugo Fisch from Switzerland and skull-based surgery training at Italy under the guidance of Professor Mario Senna. He has taken a special training with Professor Anirban Biswas, Kolkata, in vertigo and balance disorder, and has set up his own vertigo setup. I hand over session to Dr.
Dr. Sanjeev Kumar, who is going to present about the endoscopic management of adhesive otitis and cholesteatoma. He is presently a director of Janki Hospital and Maternity Center at Kakkarbagh, Patna. He has worked as an ENT consultant for last 14 years. He has been a past secretary of AOI, BR and Jharkhand branch. Extensively trained in a various reputed ENT center across the globe. He has worked as an assistant and associate professor in Janki Medical College and Teaching Hospital at Nepal. He has attended and presented at many conferences and national symposia and workshops. He has himself conducted a lot of workshops, cadaveric temporal bone dissections, face endoscopic skull-based cadaver dissection as an operating faculty. And he has been a course director at Bihar and Jharkhand State Conference. He has given last time at AOI Con Indore guest oration. He is a founder member of Bihar ENT Academy and Research Foundation. Special interest he has in endoscopic skull-based surgery and endoscopic ear surgery. Please,
thank you, Chairperson, sir. At the very outset, I would like to thank CIPLA team and Dr. Simab Sheikh, who has given opportunity to speak at this forum. Before going to my topic, and this is a late evening, you must have tired, and a thorough academic session throughout, a very intense session has been gone through. So now I would like to show you one very inspiring and motivational video first. Just come, hello. We will see, yeah.
ये कहानी है 1938 की। कहानी है 1938 की कैरली नाम के एक आदमी की हंगेरियन आर्मी में, और वो उस कंट्री का बेस्ट पिस्टल शूटर था। जितनी भी नेशनल चैंपियनशिप्स हुई थी उस कंट्री में, उसको वो जीत चुका था। और सबको ऑलमोस्ट कंफर्म था कि 1940s में जो ओलंपिक्स होने वाले हैं उसमें गोल्ड मेडल केरली को ही मिलेगा। और उसने सालों से ट्रेनिंग करी थी। उसका एक ही सपना था, एक ही फोकस था कि मुझे अपने इस हाथ को दुनिया का बेस्ट शूटिंग हैंड बनाना है, बेस्ट बनाना है, बेस्ट बनाना है। और वो कामयाब हो गया, उसने बना लिया बेस्ट शूटिंग हैंड। सिर्फ 2 साल का फर्क। 1938 में एक आर्मी का ट्रेनिंग कैंप चल रहा था, क्योंकि वो आर्मी में था, तो एक एक्सीडेंट हो गया। उसके उसी हाथ में जिससे उसने गोल्ड मेडल जीतना था, उसमें एक हैंड ग्रेनेड फट गया और वो हाथ चला गया। जो उसका सपना था, जो फोकस था, सब खत्म। ये होती है स्पोर्ट्समैन स्पिरिट, कि इतना सब कुछ होने के बाद भी तुम यहां पर आए हो हमको देखने के लिए और हमारा हौसला बढ़ाने के लिए। किसी को नहीं पता था कि वो 1 साल से अपनी ट्रेनिंग कर रहा था लेफ्ट हैंड की, और उसने जवाब दिया, मैं यहां पर तुम्हारा हौसला बढ़ाने नहीं आया, तुम्हारे साथ कॉम्पीट करने आया हूं, तुमसे लड़ने आया हूं, तैयार हो जाओ। और कॉम्पिटिशन हुआ, बाकी सब वहां पर जितने भी लोग थे वो कॉम्पीट कर रहे थे अपने लेफ्ट हैंड से। वो गया, पूरे वर्ल्ड के बेस्ट शूटर्स आए हुए थे जो अपने बेस्ट हैंड से कॉम्पीट कर रहे थे, और ये अपने ओनली हैंड से कॉम्पीट कर रहा था। और कौन जीता? मैन विद द ओनली हैंड। लेकिन वो तब भी नहीं रुका। 1952 ओलंपिक्स, दोबारा कॉम्पीट किया उसने, और इस बार गोल्ड मेडल कौन जीता? दिल्ली। 4 साल बाद दोबारा से, और पूरी की पूरी हिस्ट्री को बदल करके रख दिया ओलंपिक्स। इस पर्टिकुलर कॉम्पिटिशन में उससे पहले किसी भी एथलीट ने लगातार 2 गोल्ड मेडल्स नहीं जीते।
So I hope I tried something to tackle single-handed versus double-handed. Now my presentation is actually beginning with in conclusion. While going through the research and surgical work done around the world for cholesteatoma surgery, I came to the conclusion that there are mainly 3 objectives in all methods of surgery: complete removal of disease, preservation of normal healthy tissue as much as possible, and reconstruction. So far, the treatment of chronic ear disease is all about treating the battle scar. It means treating the perforation, osteoplasty, and often we ignore underlying ventilation problem and hope they have gone away. So failure in ear surgery is equivalent to failure in ventilation. And if you want good hearing result, you have to make well aerated middle ear. It is not about the implant. It is not about at all the mastoid. So the principles of cholesteatoma surgery is the 3 objectives we are just changing. And about judgment, who am I to judge at this stage? And it is too early to judge which one is better. But when you are going to do cholesteatoma surgery, these 3 objectives go hand to hand, and you have to have a very meticulous balance between these 3 objectives. You can't give less importance to any of one objective. So many research and many works all around the world, ultimately they are coming to the preservation. some applied, some researchers have advocated canal wall intake technique. So I think endoscope has extra range of flexibility to give some kind of meticulous balance, because endoscope has superior panoramic visibility as well as the synchronization of dynamics of visibility with the surgery. Unlike the microscope, it lacks panoramic view and less synchronization. In fact, I say no synchronization with surgery. You have to, every time you have to shift, and it is almost segmental visualization when you go through microscope. Of course, it is depth perception, 3D, whatever you can talk. And to compensate that less visibility and less synchronization, you go on destroying the healthy tissue. In fact, and further you have to correct that. For that correction, for lost synchronization and lost visibility, you go on destroying the healthy tissue, and ultimately you land up with the point of no return, and the reconstruction will be almost impossible at that stage. So that's why I advocate endoscopic approach of cholesteatoma surgery. And I think in my practice, I have in last 3 years, what I am doing, I am getting a very wonderful and encouraging result. The steps of endoscopic cholesteatoma surgery is canal access, obviously, and we choose a wide canal for the 4 mm telescope. Choice of approach maybe differ, sometimes anterior to posterior, sometimes superior to inferior. Bone removal is most important. That should be focused and that should be adequate. Removal of disease is certainly a good goal, good aim we are chasing for. Visualization of extent of disease is very important, and that will give you idea what structure you are going to remove, what type of structure you are going to remove, how much bone you have to remove to clear the disease in toto, and ultimately reconstruction. So most cholesteatoma are manifestation of retraction pocket, we all know, and primarily it is a disease of middle ear and tympanic cavity. It extends from there. The aortic is the most commonly involved, and most recurrence occur with the tympanic cavity and its extension, not the mastoid. These are the post-operative video snap of mind reconstruction. This is after 2 years, 2.5 years. This is after 2.5 years. This is extensive cholesteatoma. I constructed with a composite cartilage based on perichondrium. This is aortic cholesteatoma. This is a reconstruction after 2 years. This is again a aortic cholesteatoma with up to extension up to the antrum and aditus. So this is follow-up picture of 1.5 year. This one it was a very extensive cholesteatoma, and after 2.5 years you can see well ventilated middle ear. This is again 2.5 years. Post-op picture more than 3 years. I haven't done anything because I just look and go and clear with a small corridor and give that temporal fossa and the canal skin. This is adhesive, again adhesive. So this, why the mastoid, why not the canal? So let's see my video, then I will answer. This is a case of aortic cholesteatoma, and I use otoendoscopy is a valid and very tremendous tool to assess what you have to do further. So I can see in atic area there is a squamous cell going, squamous epithelium going inside, and there is some pooling of secretion. And complaint was foul smelling discharge with normal hearing. And here is the challenge: how you do this surgery not to disturb the hearing. And I went with that 4 mm telescope. We have taken U-shaped, inverted U-shaped incision from 3 o'clock to 9 o'clock, almost 1 centimeter lateral to the bony annulus with the circular knife, and go on elevating the flap till the disease. And this disease is because of the collapse of Prussic space and ultimately leads to atic cholesteatoma. And the ventilation of Prussic space is from the pouch of von Throls. So here is the pouch of von Throls, almost blocked. With the help of curved needle, just and for the bone removal, I avoid to drill with the power instrument. I use curette, sometimes osteotome, sometimes Carrison punch, and with help of carotenoid, Adeline soft carotenoid ball, we are removing gradually the cholesteatoma. This is, you can see the epitympanum just above the tegmen, anterior epitympanum we can see clearly. We need further bone removal over the posterior epitympanum. After doing that, you can see epithelium over the superior and slightly middle part of the oscles. With the help of curved perforator, we are just removing the medial part of the epithelium. Must be gentle while removing. Yes. How beautifully we remove the medial part of the epithelium in the epitympanum. Bit by bit we remove. Have patience, go slow. So this vision is extraordinary. We won't get in microscopic. Yes. Now the last bit of the epithelium. So here we can have very good anatomical landmark we can appreciate. This is a here, where is a pointer? This is anterior malleolar ligament, this is anterior epitympanic space, and from here if we draw a line from inferior to superior, it divides the anterior epitympanum into posterior epitympanum. This is intact intact incus, and we can appreciate the incadomerial joint, and this is a lateral part of the neck of malleus. We have a supratubular area visualization, and through. So if you think about the ventilation will start from here and just travel through the entire submalleal space, and by this route, by the anterior isthmus, go to the epitympanum, and another route is travel, it goes to the editus and antrum. So in 75% of cases, it is in case of complete tensor fold, it won't go in that way to ventilate the epitympanum. In 25% of cases, when tensor fold is absent, that Palva has suggested, so the ventilation follow this route. So if in this way, if we are maintaining the ventilation as well as preserving the anatomy, it is wise to do this way than to destroy the bony structure to see this part in tremendous way. Now we can have a very good view of all the skills assembly, and we can check the round window reflex. Yes, we can appreciate very well. Yeah. And with the help of eyelid of tragal cartilage based on perichondrium, we repair the lateral wall of the epitympanum. And after surgery, I want any hearing deterioration, so I achieve the goal without disturbing any hearing. We do the removal of disease. Now next case is slightly, so autoendoscopy, we can appreciate here that there is a keratin, a lot of keratin. Yes. A lot of keratin in the atic area. And here there is a keratin as well as this retraction going deep. We are not able to visualize even the angle is scope. And we can appreciate the loss of ossicular, loss of incus stapedial assembly as well as medialization of the malleus. And this part of the whole TM is adherent. Slight air pocket in the anterior part of the mesotympanum. When we go on doing this surgery, in this case, we approach from anterior, elevated the anterior flap, and we can stay here like slightly, because this is something very innovative I had adopted for the endoscopic ear surgery. If you think about the overhang of this bone, particularly the whole this bone, what we can expect inside this bone? If we have lost assembly of stapes and incus. So only a wandering incus we can expect, and far lateral and slightly superior we can expect the editus and the antrum, and posterior to that the big mastoid cavity. So there is no danger to use this osteotome to remove that bone, so that there will be easy reconstruction and a stable and permanent reconstruction in future. So I make a window to see the disease extension. After doing so, we can have a large chunk of bone we have removed. So now we can visualize the most anterior and posterior part of the epitympanum, and we can assess the disease where it is going. And with help of curve suction, And this is case of this cholesteatoma is sac-like cholesteatoma, and matrix is like sac. So removal of this cholesteatoma has become easy. In case of infiltrative, it is difficult to remove from the endoscopic approach. So I do a lot of irrigation to break the adhesion between the cholesteatoma and the mastoid epithelium, because we have to preserve the mastoid epithelium, especially periantral area. And with the help of lot of irrigation, we are removing the cholesteatoma from the mastoid cavity beyond the lateral semicircular canal. It was certainly a big cavity full of cholesteatoma. Again, need a lot of irrigation. So we use a curve suction, microsuction, as well as some curve instrument to see inside the mastoid cavity and to remove the sac of cholesteatoma. This is from the periantral air cells, peritegmental air cells. Now come to the middle ear and retrotympanum. With the help of alligator forceps, so we won't be expecting any suprastructure of the stapes. So the cholesteatoma is almost slipping over the stapes foot plate. With the gentle traction, we are removing it. So this cottonoid ball is giving a tremendous advantage during the surgery. Every time mopping and avoid the need to do suction every time. So here the facial canal is almost open, and with the round knife we are just clearing the sinus tympani and facial recess. With the help of curve suction, now I'm so anterior extension of cholesteatoma can be visualized with the same approach, and we can follow it and remove it ultimately. We can see the supratuval area. So preservation of the skin is most important, as well as preservation of major part of the bone for reconstruction. So here we can see the supratuval area and the anterior. So here we can see what we have achieved by doing so. Mesotympanic cavity having almost covered with the mucosa, as well as we have removed less amount of bone during surgery, and so it will help in making a middle ear functional for the longer time. We have already given a temporalis fascia inside the mesotympanum to reconstruct the defect of tympanic membrane, and this is a full thickness tragal cartilage. So now its canal has almost take a new look, and this is again tragal cartilage. as a vertical stud, and it seems very stable now. Flap arrangement is needed here. Yes. So 4 mm telescope is wonderful. After 6 months, we can see a well aerated middle ear. There is a valsalva, the TM is bulging here, and we can appreciate the tragal cartilage here. Yes. Next case is a slightly difficult one. Here, autoendoscopy gives many things: anterior atic retraction, PS retraction, as well as granulation tissue. And here we can appreciate some blue hue in the hypotympanic region. And we palpated, and we do even needle aspiration, and high jugular bulb was confirmed without any bony covering. Most of the time we do a surgery on high jugular bulb with the bony covering, so it's less chance of any risk during surgery. In this case, as we took inverted U-shaped incision. Before that, this is again innovative idea to do hydrodissection. Hydrodissection of the plaster dome. How we do it? We took 26 gauge needle and find out the air pocket inside the middle ear, where it is. And with the help of this needle, we pierce that plaster tympanic membrane whenever the space is in the middle ear, and pushing some normal saline, we can have a wonderful look of bulging TM, we can see. So by this way, we are lifting the plaster dome, tympanic membrane epithelium, and at the same time we avoid damaging the middle ear mucosa, which is very vital in restoring the function of middle ear for the longer time. Again, we need more one. So again we took incision. We are going some. So knowing that we are going to face the high jugular bulb, we was very meticulous to do sharp dissection without pulling. And while doing, there is some very difficult situation we face by putting pressures of from the cottonoid ball, and we approach from anterior and superior. We went there, and this is tricky. Something to be discussed. Here is the posterior pouch of bone of Thralls, and because of slight inflammatory changes earlier and inflammation, whatever the infection, there is a fibrous band blocking the ventilation of Prussic space, and Prussic space collapses and do atic retraction and goes to the mastoid cavity, leading to cholesteatoma. So we remove that with the help of 90-degree curve needle. After removing all this, here we will stay here. So after removing this chunk of bone, we can see cholesteatoma going inside and wrapping the incus from the lateral surface. Yes. So we remove all the oscles. Again, achieve the healthy, rather undamaged middle ear mucosa, as well as we can appreciate the high jugular bulb, and we repair with the temporal fascia and the thin slice tragal cartilage based on perichondrium. And we use, in this case, we use autologous oscles to raise the height of a stapes. Thank you very much.
Nice presentation, Dr. Sanjeev Kumar. I fully agree with you that endoscope is an excellent tool and it should be tried. There is no point in having a debate that microscope is better or the endoscope is better. The questions from audience?
I think most of, we are tried with question, I think.
One part.
Why don't you use the drill?
Yes, I do want a good control inside the middle ear when you are going with the endoscope, because lesser space, and two things is very important. The canal skin is very important. You may lose the canal skin while going through drill, power instrument. One thing, when you lose the canal skin, it will be very difficult to reconstruct the middle ear. Second, while drilling the bone, what amount of bone you have to remove? So I need a better control by doing this way. That's why I avoid drill inside the middle ear when you are going to do with endoscope.
Okay, thank you.
Any question?
Any questions?
Thank you very much.
Thank you very much, sir.
We are coming to the end of the sessions, but before we close, we will have a small felicitation ceremony. We would like to felicitate our faculty members by presenting a moment to them. So first I invite Dr. Seema Sheikh to present a memento to Dr. Bharat Purandare. Dr. M.K. Rajsekar. Sir, please. So I invite Dr. Seema Sheikh and request him to present memento to Dr. M.K. Rajsekar. Sir, please be there. I now invite Dr. Samir Bhargav and request Dr. Seema Sheikh to present memento to him.